Good morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. We have several hearings planned today, but before we get to them, I'd ask you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. I'd like to welcome Representative Steve Kesselring to the committee, sitting over there. So welcome, Representative Kesselring. The first bill to be considered this morning is HB 70-FN. The prime sponsor is Representative David Nagel from Belknap County. And Representative Nagel, if you'd like to come forward and introduce the bill.
Thank you, sir. It's a pleasure to be here. As you know, or you just said, I was very proud to create a bipartisan coalition to truly represent the needs of Gilmanton, Guilford, and Ward 2 of Laconia. And it's my honor to present this bill to you, which is not simple. It's common sense to me, but I know to other people it may not be. So I would ask you to bear with me as we go through this. Just as a preface that I feel obligated to say at this time, I am the luckiest person in the world. And I know I'm quoting somebody else and saying that, and no, I do not have a bad neurological disease right now. But I really am. For most of my life, I've been able to advocate for the rights of those who are stigmatized by those around them, too often those who had promised to help them. For the past 40 years, I've been able to do that for a living, and that is such a blessing. As rewarding as that can be, at times it's really challenging. And such times, I draw strength from this book. I read this first when I was 12 years old. It's the Gale Sayers autobiography. He was a famous professional football. Had it not been for knee injuries, we would probably be talking about him as the greatest player in NFL history. Unfortunately, that did happen, and he saw that as a blessing, which was very strange. But the book was about his life and his relationship with a gentleman named Brian Piccolo, who later died of cancer. Gale's black, Brian's white. Back in the 60s, that was a really interesting thing to talk about, a relationship like that. Brian Piccolo later died. They made a movie called Brian's Song, and that was based on this book. But that's not what I wanted to say. The title is I Am Third, and what that means is the Lord is first, my friends and family are second, and I am third. And it's a very interesting take on the golden rule, but it's something that I've dealt with, or it's been my motto my entire life, and I thank him tremendously for that. While life can be challenging, it is infinitely less so because of the support that I receive from so many people around me. And there's nothing that I could have done in my life, whether it's at church, my work, my advocacy, my authorship, that I could do without that. And I'm really thankful. And with that, I'd like to talk about HB 70. Just for your reference, oh God, why does this happen? Here it is. There is an amendment to the bill, which we'll get to, but as you know, I wrote a book called Needless Suffering. The good thing that comes with writing a book that actually has some level of popularity is you get to travel all over the country, meet all sorts of really neat people, and do all sorts of neat things. One of the subjects in my book was the whole concept of electronic medical records and how I think they are a problem. So, you know, whenever you're experiencing something, a lot of times you think you're alone, and that nobody else feels the same way. So one of the meetings I was giving a talk before a bunch of family practitioners, and I thought I should say something. So I said, if I had my way, I would take the electronic medical record, I would throw it to the bottom of the ocean, I would never bring it back, and leave it at that. And I thought I was going to get rotten tomatoes thrown at me. I thought, you know, whatever. Quite the opposite happened. I got the first standing ovation in my entire life. Positive reinforcement. So whenever I gave that talk, and I've spoken all over the country, I said the same thing, and everywhere I get the same response. So if that's the case, then why do we keep doing it, and what's wrong with it? And that's what HB 70 is designed to fix. As you know, some of you know, this bill passed by consent in this body last year. This is something that's bothered me a lot. It went to the Senate HHS. I was asked to put it to interim study by certain people. I was told by Senator Prentice that the bill would have passed without a question, and had I not agreed to interim study. It was my understanding, for you neophytes here, that the Senate actually did interim studies. They do not. So the bill functionally died with my agreement, which really bothers me a lot. With that said, we did talk over the summer, and that's what the amendment actually addresses. As we proceed, I think there's two principles that guide me that I think that we need to think about. First, and it's, read along in your handouts and your hymnals, all right? I'm not going to go through all this verbatim, so, but these two are really important. I've been doing medicine for a long time. The first one is the doctor-patient relationship is the most important diagnostic, therapeutic, and human tool in healthcare. Any public policy intervention which adversely affects the sanctity of this relationship should be viewed skeptically and only supported after an exhaustive review of risks and benefits, both intended and unintended. Second, this is really important for a lot of things we're looking at in this legislative session. Private practice, unencumbered by unnecessary oversight by the medical industrial complex, has been the bedrock of American healthcare. The progressive destruction of this entity, intended or otherwise, will be the lasting and unfortunate legacy of healthcare reform. It is my belief that the AHR fails on both of those counts, and that's why I brought this bill forward. I'm not going to read the next part. In 1981, I engaged in a debate on pros and cons of computers and healthcare, and those 7 items that I list there are the things that I said would happen if we went down this road. Every one of those 7 has happened, which makes me functionally Nostradamus. It didn't really need to be this way. In 2004, State of Union President George W. Bush proposed the electronic health record by saying that we can avoid dangerous medical mistakes, reduce costs, and improve care. He was implying that the EMR would be used to facilitate communication between providers. It didn't turn out that way, with the creation in 2009 of what was called meaningful use, that we jokingly call meaningless use by CMS, and later changed the name of managing interoperability, which I have no clue what that means, but it means something to them. They thought that, I don't know what they thought they were doing, but what we do know now is that the intent was not to facilitate communication, to not improve patient care, but actually to facilitate maximal billing and revenue and collect data for public health and other professionals. It's actually not facilitated communication, which is a problem. I will not get into the adverse effects on providers. Dr. Colligan, who is speaking later, will get into that. She's way smarter than I am about that, but we'll talk about that later. The other thing that bothered me is when CMS introduced this, they told us that we could do it if we wanted or not, but if we chose not to do it, they would withhold 15% of our fees. So if Medicare, they will withhold 15% if you don't comply. And I personally, as a doctor, am insulted by that. And that's basically what killed private practice, is because they had to give this incredible technology investment to comply with that. That's another long story. The only other thing I'm going to read is the next statement. It comes from Eric Topol. He's the founder of Scripps Institute, which looks at translational stuff. He's very smart, way smarter than me about technology. The good news is both he and I and Dr. Woods graduated from the University of Rochester Med School, so he's obviously very smart. But he said the following: I think that the electronic records have been the singular biggest disaster in the last 2 decades of healthcare. The idea was right, but the execution has been pitiful. They are set up for billing purposes, which I said. They couldn't care less about the patient's citric vision, which I said, violation of both principles. They're pathetic. They're the worst software in existence that I know of. They've really taken us astray and have given the whole digital area in healthcare a bad name. They're uniformly hated by patients and doctors because they involve such poorly performing user interfaces and are the single worst part of the deteriorating doctor-patient relationship. I didn't need to say anything else. All I had to do was read that because he's way smarter than me. Needless to say, and I will leave this to Dr. Colligan to discuss, it's one of the leading causes of physician burnout, and we're dealing with healthcare shortages. Doctors especially, that's a common reason. Why do doctors go into specialties and not primary care? Because they can't afford to. That's why, and that's why we have shortages. HB 70 is a solution to a very real commercial insurer problem. All federal insurers mandate EMR compliance, even though they technically don't, but they just hold back your money if you don't. As of now, I'm pleased to say that local commercial insurers do not require this, and they're going to say that this is a solution in terms looking for a problem. I call it an ounce of prevention. We're witnessing an unprecedented oligopolization of healthcare and health insurance in this country, and there's virtually nothing to stop mega insurers from following the lead of CMS, which has always been the rule. Whatever Medicare does, private insurance follows. MCOs representing New Hampshire Granite Advantage program have more than implied this at public hearings where they referred to it as a carrot and a stick. Anyways, I've said most of that. I believe personally that this will create a renaissance of private practice and dramatically improve the quality of healthcare, decreasing cost, increasing access, and improving efficiency. With that said, I'm going to hand this out to you guys. A little old lady gave me this. It cost her virtually nothing to make, unlike that little health. And all it does is say what her problems are, what her allergies are, what her surgeries have been, color-coded, plasticized, and she handed it to me in 2 seconds. I knew everything I needed to know about her. It takes me hours to figure out from an electronic record if I ever do know what's going on with that patient, which is really a sad statement. And when we're thinking cost benefit, because that's really important here. The people that I'm really watching out for here is, it may be that doctors, allopathic doctors are a lost cause. That's sad, but it may be. However, a lot of what we're trying to do is bring other people into the fold, acupuncturists, chiropractors, massage therapists, other people that provide a valuable healthcare service. We want them involved. You know what I hate about them? When you look at them, they're all smiling, they're happy. When I look at doctors, they're miserable. And I go, well, why are you happy smiling? He says, I have to deal with insurance companies. It's wonderful. And I said, well, why do you want to deal with insurance companies? They all say the same thing. It gives me access to patients that need my services. So what I want to do is I want to protect them from going down the same mess that doctors went down for, that they don't have to make this humongous investment in technology that'll make them prone to being, going down the same corporatization that doctors have gone through. The last major comment I will make is that the fiscal note on this bill really bothers me a lot. The electronic record has been unnecessarily and excessively costly. This is a reason to lower cost. For them to even suggest that it's going to increase cost to anybody in the long term really bothers me a lot, because it's just not true. The bill itself has 3 parts. I define EMR. The second part's a series of things called private provider protection. All the amendment does is it puts in the words, or any other information required for the purpose of obtaining prior authorization. That's all it adds. And the reason why was because of our discussion, the insurers were concerned that they wouldn't be able to get the data they needed for that, and I thought that was a reasonable thing to add. What we did remove last year was the patient protection portion that we're dealing with separately. With that said, we have a job to do. Our job is to put the needs of others at or above our own. That's what healthcare is all about, or what it should be about. When something gets in our way, it needs to be eliminated. And that's what the purpose of this bill. It's not to eliminate the EMR, but to maybe take a step way back and try to make it what it was supposed to be in the first place, something that actually is cost effective and facilitates communication. That's what the purpose of this bill was. I hope you can support it. And thank you. I'm ready for any questions.
Representative Palazov.
Thank you, Mr. Chair, and thank you for introducing this bill. Uh, what would you think about some sunset amendment? Because if this bill is addressing issue that might be fixed in the future, for example, if CMS rules that started in 2009, not so long ago, if they will be reversed or if there will be some better IT system for EMR introduced that will be producing like a single view what's happening with patients. So maybe like in a year or two or in 3 years, maybe we won't need this law anymore. So what are your thoughts on that?
You actually brought up a point that I kind of forgot to make. Number one, there is a precedent for this bill. I'm not directly answering your question. I'm being a politician and answering it in a separate way. Last year, I passed the prior authorization bill that I wrote with a bunch of other people, like 100 other people. And that bill actually did create separate formats for filing prior authorization that you could do it either electronically or not. So basically, this is doing the same thing. I'm not against the concept of EMR. Like one of my friends is an acupuncturist and she has an incredibly cheap EMR system that works really well for her. If you can do it cheaply and efficiently, but not have it interfere with what your interaction with the patient is, then it's fine. I personally have a no computer rule. There are no computers allowed in a patient room ever. And the reason why is because I just don't want something to get between me and them. And that's why I don't wear a white coat for the same reason. I don't want something to get between me and them. That's never going to change. Dr. Oh God, I can never remember how to say his name. Sorry. Dr. Topol. He's of the belief that artificial intelligence will solve all of our problems, which I think gets to what you just said. Excuse me for being skeptical. I don't believe that. Every patient's an individual and artificial intelligence will never, ever substitute for our humanity. Does that answer your question?
You're all set, Representative Lucas and then Representative Lamontagne.
Thank you, Mr. Chair, and thanks for taking my question. This is a would you believe question. Would you believe that over a very brief period of time, I had to learn 5 different EMRs, reflecting 3 different hospital systems, my own private practice, and the clinic where I taught. That required attending seminars over weekends, taking time away from family that I didn't have to begin with. And there's one other thing about the advent of EMR that greatly troubled me, and you touched on it. I was horrified when I began to see medical students and residents who spent more time looking at a screen than they did making eye contact when they would ask patients questions about their symptoms.
Answer that with the would you believe? Would you believe that I created a program at the University of Rochester to focus on the teaching of doctor-patient communication with regards to pain management? But when I asked them, I said, how do you guys deal with? And they said, our job is to teach them how to interact with patients, and that's what we do. The computer can come later. And I'm very proud that my university still does that. So thanks for bringing that up. That's a horrible problem you mentioned.
Representative Lamontagne.
Thank you, Mr. Chair, and thank you, Representative Nagel, for being here and for this bill. I'm wondering, though, given the concentration of healthcare businesses, like in my area, Mass General Brigham has bought up the hospital, just about every private practice. How, if they have their own medical record, how anyone that has to interact with that network can not also have to participate in their medical record system?
I'm looking more broader, a lot broader than that. I mean, if an institution chooses to use that for their own thing, like for example, you know, I interact regularly with Dartmouth, I interact regularly with the VA. We don't interact with their systems at all. And they're not, I mean, the VA system's horrible. I don't care what they say, it's horrible. I think Dartmouth's system's not a whole lot better. When I get records from them, it takes me forever to figure out why the patient's even there. You know what we used to do? We used to actually call each other. And we would call the doctor up and say, this is what why I'm referring the patient to you. This is what I need from you. We called each other. The least frequently used app on my phone is my phone now. But back then it was. And there's some wisdom to that, because person-to-person communication is way better than electronic communication, especially when you're dealing with complex issues like this. So I'm not really persuaded by that argument. If they want to do that, that's certainly their business. Again, I'm really worried about chiropractors, acupuncturists, and massage therapists and people like that who've not been forced to go down this road, to allow them to have, to be able to focus on what they do best. I mean, I'm always jealous of them, because they, not just because they're happy, but they do what I wish I could do. I don't know if that answered your question, but the other little minor detail that's relative to what you just said that we need to be really worried about. I work with the Department of Healthcare Economics, the University of Rochester, and one of the things that I've heard before, he wasn't the first person to say this, is that within 10 years, we will have an oligopoly of insurers and healthcare providers in this country. We're already seeing that happen in this state. CMC. And, I personally think these are incredibly dangerous precedents. And I think that we need to do anything that we can do to stop it. And one of the things that we really need to do is promote for and advocate for private practice, because I'll be honest, we did much better then than we're doing now. That's my opinion. Anyways.
Representative Palmer, did you have your hand up?
Thank you, Mr. Chair. So, I mean, I've lived most of what you've just said, and I agree with 99%. And the only concern I have is this. So we just had a local practitioner who maintained his private practice until I think he just retired, and he was either 98 or 99, and he only got a fax machine, 5 years ago. But the main concern I have, and I think, most people, he did answer the phone. Most people, he had access to the Dartmouth system. So when his patients went to Dartmouth and saw the cardiologist, he could or rather his secretary could look it up for him and print it out so he could see what happened. And I just want to be reassured that nothing in what you're proposing here would stop that. And the other thing is that somehow if my patient goes to another practitioner, that we have a way to get that information to our chart, probably a faxed copy that gets scanned in. But that would be my only concern. Just because in the old days, you would see a patient in follow-up and you wouldn't be able to, they went to see the neurologist and that report wouldn't be there and it would be a wasted visit. Now that almost never happens.
So back in my day, like in our day when we were young, we always had the records. We didn't need a statute to say you have to send a record. I had no trouble. If a doc referred me a patient, I'd get something in the mail or whatever. It happened right away. But would you believe that I only agree with my wife 70% of the time? So if you agreed with me 99% of the time, I'm not sure if our relationship is really ready for that. But if we agreed on everything, that would be, and again, there's two other comments that I wanted to make. One was that I have no problem with an EMR. Like, I love our EMR Acopa. Like, it looks the same as the record we used to use. It's, it's not in paper form, but it's the same format. When a doctor writes a note, that's where you do your thinking. And if you have to stick your notes in a template, that's what most of these EMRs do. Then all of a sudden where's the thinking go? And I asked Acopa also, the 15% thing, I asked him, how much does it cost us to comply with that 15%? And I couldn't get a good answer, but I said, if it's more than 15%, why are we even complying at all? But I love our EMR, but apparently now we have to change it and we're going to follow everybody's lead, which bothers me a lot, but that's life.
Representative Woods.
Oh, thank you, Mr. Chair, and thank you for listening to me, the old dinosaur, as you refer to me. Yes, for people who gather, we did practice in the same office. I retired 11 years ago, and I was not faced with that. I did all my activity face to face. Having said that, and referring to what I interpret as the inevitability of the EMR, although we're trying to make some changes, what in your mind is the major impediment to achieving an EMR that's meaningful? And when you're done, I'll offer my thought.
Can I say greed? So, when we start, I'm like, as President Bush had suggested, that was an honorable path to follow. And why we deviated from that path, I have absolutely no idea. But, the way it got designed was this might have been after your time. I don't think so. But, it was all you had to have so many bullets to bill for such and such a level. The whole EMR was designed to make sure that you got enough bullets in to be able to bill a certain amount. That's like perverse, but that is how it was designed. And then with meaningful use, like every time you go to your doctor and you ask, are you wearing a bicycle helmet? Do you feel safe in your house? Is your gun locked up? All those questions, those are public health questions. And I'm still never sure how that public health information gets from my EMR to them and considering HIPAA and all that other stuff. But that's why that data is being collected. I was at a meeting of the National Pain. I was part of the National Pain Strategy, and there were like 200 docs in a room, and they were trying to figure out, well, our problem is lack of data. So they were going to use this as a means of getting meaningful use, as a means of getting more data. So then they listed all the questions that they wanted to add to meaningful use. And then I raised my hand and I asked, is there anybody else here that actually practices clinically? Not a single person raised their hand but me. And I said, do you know what doing that's going to do to my time with the patient? And it was kind of like earth-shattering statement, but that is what it's designed for, just those two things. If it could be redesigned like our EMR is at Concord Ortho, that it facilitates communication, and that when you see the doctor's note, you know exactly why the patient's there, what their problems are, what their allergies are, what their surgeries are. Like that plastic thing I just handed out that cost nothing. My wife did that for me yesterday. That cost me something.
Do you want this back, by the way?
Yeah, I guess you can have it. But
have it back.
that's what I think the EMR should become. There's and I would say that greed is the big barrier that we need to get over.
Follow up.
Would you believe I sort of agree in the sense of greed? I call it the corporatization of medicine, or the fragmentation of medicine. And would you believe that a single payer would obviate a significant part of this problem? And I submit an example, and people here are not, and I'm sure you are familiar with, the healthcare system in Singapore, where you carry a card like a driver's license, and it's updated every time you have an encounter electronically. And you walk in, wherever it is, and you give them that, and it's put into the computer, and absolutely every item is in place. That's an ideal EMR. Is that how you envision that transition? Not discarding the EMR, but your bill is a step to gain that endpoint.
I would agree with that up to a point, but this is my concern. The type of patients I deal with. I deal with patients that have really complex disabilities. I deal with patients that are stigmatized on a regular basis. Their problems don't lend themselves to an easy diagnosis. So doctors will throw all these little diagnoses in there, but the one I hate is opioid dependency. When I have a patient that's being managed successfully on opioids, and one doctor, only takes one, puts opioid dependency on, that gets in their problem list. And you know how hard it is to get that out of that problem list? And that person is now further stigmatized forever. I had one patient, no lie, all they got was Valium for an MRI. And somehow that got translated into anxiety disorder. That was 10 years ago, and anxiety disorder is still on their medical record, and we can't get it off. That was the whole purpose of the third part of this bill, which we took off, which was the patient protection portion, is we needed to find a way to do that. If you can figure out a way to make it adaptable so that when the information on there is wrong, when it tells you exactly what they're there for, when we're not serving somebody else's needs other than the patient's, if we can do all those things, then that's great. But I think we need a dramatic reset to do that. And I'm not convinced AI is going to help that. I'm not convinced.
Representative Hartnett.
I'm sorry to take all your time. Keep going. I'm sorry. This is fun for me.
Thank you, Mr. Chair. Good to see you, Representative Nagel.
Thanks. Nice to be
Appreciating this bill. Let's assume that it passes. What do you imagine might be the kind of next generation of legislation that would follow this?
I believe personally that legislation is too often an unnecessary evil. I think that this is a start, a shot across the bow maybe, but I really think that what we're doing at the state, and we've done this with other things, with prior authorization bill. We passed a bill a couple years ago on opioid dependency and morphine milligram equivalents that set the stage for change all over the country. And that's kind of like the way I look at this. It's got to start somewhere. And, you know, yeah, the commercial insurers are right. This isn't a problem in our state right now, at least as far as they're concerned, but it could be. But at the same point, with prior auth, not only did we make a change there, but we made a change with CMS too. You need to have both of those things happen. And then all of a sudden, you know, a little pebble becomes a big ripple. And that to me is what I'm trying to do here. The sad part is when you travel all over the country and get the same standing ovation for saying the same stupid thing everywhere, that's a problem that we need to do something about. So that's what I envision next steps is we take this federal. And I actually already met with our legislators in Washington to talk about that. So it's a start. I used to have a friend that directed HHS in Washington, and we started that discussion, but you know, like those jobs aren't there forever, you know, so.
Any other questions? Representative McKay.
Thank you, Mr. Chairman. I don't know how to ask this question, but I'm concerned about the state telling doctors how to structure their records. But I wonder, do they do the same thing for the changes that have happened? Like there are nurse practitioners, there are chiropractors, there are social workers, there's all kinds of people who see patients, who keep records. Are they required to follow state law? And if you have any opinion as to why physicians have been pointed out.
Anybody that participates with CMS in any way, shape, or form has to participate. If you participate with the managed care organizations in the state through the Granted State Advanced Medicaid program, you have to participate. If you have to practice through Medicaid, you have to participate. If you're strict fee-for-service, direct care, whatever term you want to use to call it, you don't have to. So it's just them. But anybody, like if I'm a chiropractor and I bill Medicare, I have to do this. Yeah. I mean, I don't have to, but they're going to withhold some of my salary. That's all.
Follow up.
Follow up.
Would you consider legislation to eliminate this state requirement?
You know what's funny? We apparently don't like mandates. So we got a mandate. So if we don't like them, maybe we should get rid of it. I don't know. I think that you need, you know, when you practice medicine, you really need to figure out what you need to do to interact best with your patient first, you know, the other people around you second. And I think you need to make that individual decision. I don't think it's right for somebody to tell you. I personally think if CMS wanted to do it this way, it shouldn't have been a 15% reduction. They'll give you 15% more. You know, it's positive reinforcement, not negative. And I think that would have been a better way to have done this. But, Yeah, I don't know. I'd have to think about that. That's a good question.
Representative Markell.
Tune in later.
Thank you, Mr. Chairman, for allowing my call. So Representative Nagel, are there other states with similar legislation, number one and number two? What is the position, to your knowledge, of any of the medical professional associations on this view?
So, to answer your first question, no, I really enjoy being a voice crying in the wilderness, and that is what this is. Secondly, last year I never approached them this year but last year the Medical Society and the Hospital Association did support this. The U.S. Pain Foundation supports this, the chiropractic organization, the state supports this, the Acupuncture Association, the state supports this. I've not talked to the massage people, and the psychology people did support it last year. I did not do my due diligence to get their approval again this year.
Other questions? I think that's it. Do you want this, Representative Nagel?
Sure, my wife would appreciate
It's very
it.
creative and a lot of work went into it, and I'm not sure what I'll do with it, so. Thank you. Thank you.
I'm sorry to take so much of your time last year. This took 5 minutes.
Also signed up to speak is Sabrina Dunlap from Anthem Blue Cross and Blue Shield.
Good morning, Mr. Chair and members of the Health and Human Services Committee. Thank you for the opportunity to speak. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem. We are opposed to SB 70 for a number of reasons, I believe all of which I've discussed with Rep. Nagel. We've had some very good discussions about this bill. And it's true, in general, we do think the bill is a solution in search of a problem. As Rep. Nagel noted, CMS led the charge on EMR. It was not commercial carriers, and so we did not create the current world of electronic records. We're just living in it. And so, notably, we do not force providers to use EMR. Many do. But to the extent we and providers do use EMR, we need to be able to use it properly. And one of the major problems with this bill is it restricts how we use EMR and in the cases where we're already using it. And so what I mean is the restriction of requiring only certain data, particularly in Section D, is at odds with reality. There are some situations where we may need more information to process a claim, for example. And I appreciate the amendment, which I just saw. I think it improves that language. I don't think it solves the problem entirely. So I think that the bill is attempting to do something. I appreciate sort of the grievances about EMR. I think trying to sort of turn back the clock on EMR, but instead what the bill will do is limit our ability to do basic functions with providers when they are already engaged via electronic medical record. And that is quite problematic from a logistical perspective. So I think that's it, and I'm happy to take any questions, and thank you very much for the opportunity to speak.
Okay, thank you. Any questions, Representative Lucas?
Do you foresee, should this bill become law, any withdrawal of insurance coverage from a state that has this law?
Thank you for the question. I want to make sure I understand. You mean like would a carrier leave the state and no longer provide?
Yes, thank you.
That is a good question. I don't know. I don't think so. I think that in general, this would be moving New Hampshire in the wrong direction. I mean, I think the horse is out of the barn on this. It was over 20 years ago that CMS started with EMRs. And so it is the norm. I think when we compare New Hampshire to other states where Anthem does business, New Hampshire does have a lower adoption of EMR, but it is still quite high. I believe it's like over 80%. But I do think this creates some serious logistical and practical problems for carriers. So I don't know if that answers the question.
Other questions? Representative Markell.
Thank you for taking my question. How do you respond to Representative Nagel's proposition that this may be the additional cost, this may be a prime reason it's driving people out of private practice?
Electronic records are driving people.
Yeah.
Thank you for the question. I mean, I think I understand the concerns coming from providers. I mean, I have providers who seem to like electronic health records, so I guess it depends on the practice. But I guess to that issue, I would say I don't think this bill does anything to address that. If it's a grievance with EMR, I just don't see how this gets at the issue, because this is a scenario where we're already using it, where providers are already engaged with us via EMR, and then it only restricts health insurance companies in how we can engage with the providers. So that, I think, is the problem with the way the bill is written.
Okay. Thank you.
Thank you.
Other questions? Representative Polazov.
Thank you, Mr. Chair. Thank you for taking my question. Could you clarify if you remember what specifically in the amendment can improve this bill? Because if I see correctly, the amendment actually adds to the list. So I'm not completely sure.
Thank you. So talking specifically about Section D, and I think that the amendment helps because it adds any other information required for purposes of obtaining prior auth, but we use and providers use EMR for a wide range of issues, including claims processing. And so I just think D is not broad enough. And it just gets at the heart of the problem, which is if we are engaged via EMR, we have to be able to use it properly.
Other questions? Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. Given that this seems to be a fait accompli, i.e. the medical record, and having served on Anthem's board in the early years when they took over Blue Cross Blue Shield, they were not favorable in looking at this issue. Has there been a change, noting that this will be something that we appear to be living with? Do you sense any movement that there would be a honest consideration to work with all the players to try and make the medical record more patient friendly, not business friendly?
Thank you for the question. I'm not involved in our electronic health record space, but my short answer would be yes. We would always be happy to come to the table and work in a way that helps our members and helps providers. And I actually don't know, that's an interesting fact that if I understood you correctly, you're saying that the carriers were not in favor of the move. Yeah, that's interesting. So, but yes, I think we would be happy to work with whomever to try to make the system better.
Just a follow, just to encourage you to do so, I was, when I served for the American Medical Association, served on their Council on Science and Public Health, and a special subcommittee, we looked at this issue in 2005. And because we could not get any cooperation, that it fell by the wayside. And that was the power of corporations. But we would really like to see this come to the fore again.
Thank you for the question and comment.
Other questions? Seeing none? Okay, thank you.
Thank you very much.
Also signed up to speak is Dr. Ruth Holligan.
Hello, Mr. Chairman and members of the committee. My name is Ruth Colligan, and I live in Concord, and I'm here in support of House Bill 70. I'm a physician, an expert in patient safety, and a peer-reviewed research scientist in human factors. And in human factors, what we do is we study how people work in complex safety-critical systems like healthcare. Much of my work was on the impact of EMR implementation on healthcare workers. And I'm a bit of a research geek. The EMR is not all it's cracked up to be. Use of these systems incurs many hidden costs, especially with an especial burden on small practices. First, EMRs actually increase the documentation burden on practitioners. Our study showed that for every hour of direct patient contact, a provider spent 2 hours on the computer. This is outside of what we now call pajama time, which we did with a diary study of physicians who had to work at home after they got their kids to bed on their charting, 1.5 hours at home. This type of burden is a substantial component of practitioner burnout. Next, EMRs are expensive to adopt. Direct costs for a relatively simple, straightforward EMR are $150,000 to $170,000 to purchase. That's just to purchase it. Then there's $85,000 for implementation, which means getting it actually in the practice and up and running. And $4,000 to $8,000 per year per provider to maintain. These upfront costs push independent practices to close or to join up with bigger corporate healthcare and hospital systems. We call this vertical consolidation, and this has really been shown to drive up consumer costs, New Hampshire patients' costs. Adoption of EMRs pose a disproportionate burden on small independent practices. These practices are often the lifeblood of primary care and integrative care. I ask you to support New Hampshire providers and support House Bill 70. Thank you for the opportunity to speak and take any questions.
Okay, thank you. Any questions? Representative Woods.
Thank you, Mr. Chair. Not a question, but do you have some of that data? I think that's important for the committee to know the overhead costs, especially for the independent practitioners. Corporate practitioners is a non-starter because they don't pay for it.
Right.
But we're talking about the need for primary care. They tend to be smaller practice or individual practices, and that's where the rubber meets the road with this kind of difficulty. If you could provide those numbers, I think it would be very helpful.
I certainly can, and I should state that I found these numbers in a pro EHR sort of sales rag. That was the only numbers I could find that were up to date. Other numbers were back from 2010, 2015, so those were out of date. You'll see those numbers often quoted, but they're wrong. They're old. Yeah.
Other questions? Seeing none. Thank you.
Thanks. Thank you.
Also signed up to speak is Peter Bragdon from Harvard Pilgrim. Bragdon, B-R-A-G-D-O-N. Good morning. You've asked for 5 minutes. If you could keep it closer to 3, I'd appreciate it.
I will do my best. Thank you, Mr. Chairman, members of the committee. For the record, my name is Peter Bragdon. I'm a senior policy advisor at Preddy Strategies in Concord. Here today representing Harvard Pilgrim Healthcare, New Hampshire's not-for-profit health insurance carrier, and here opposed to House Bill 70. And this is a bill we've seen before. And I'll start out by saying I always feel bad testifying against one of Representative Nagel's bills because although we will sometimes disagree on things as health carriers and health providers, his perspective on things from someone on the ground and the work that he does is very enlightening. So disagree with that. And I'll start by saying, too, that I can understand a lot of things that were said by Dr. Nagel and Dr. I forget the woman's name that just spoke. So my career was in, I have a degree in computer science. Out of college, I started a consulting and software company. One of my first clients was the New Hampshire Medical Society, actually, oddly enough. But then developed software that ended up putting us on the Inc. 500 list of fastest growing companies in America. And I always told people that the easiest part of developing any software system is actually developing the system. The hardest part, and the thing that you're going to spend 2/3 or more of your time on, is making it so someone else can use it. And from all I've heard, the testimony, these EMR systems that are out there didn't take into account the perspective of the person that actually has to use it, i.e. the client. So I can understand a lot of the problems there. And I will say, and later on I'll say, there are benefits to the use of electronic medical records, but our position is in opposition to this for a number of reasons. One, we don't think it will accomplish what the sponsor wants. If you look at line 8 and 9 of the bill, basically says that only state-regulated health carriers are subject to this law. Only about 30% of the New Hampshire health insurance market is state-regulated carriers. You have Medicaid, you have Medicare, you have the VA, you have TRICARE, you have large self-insured company, all subject to federal regulation, not state regulation. So the 800-pound gorilla in the health insurance market is the federal government. And they are the ones that are requiring providers to use electronic medical records, or at this point, maybe they're not requiring it, but as Dr. Nagel says, if you don't use them, they take 15% away from you. So they are essentially forcing people, coercing people to use electronic medical records. Dr. Nagel said, he repeated my line from last year, what was, it's a solution in search of a problem. Line 10 says we can't require a healthcare provider to use electronic medical records. We do not require healthcare providers to use electronic medical records, nor do we have plans to require them to do so, nor do we know of any other state-regulated insurance carriers in New Hampshire that require providers to do that or intend to provide providers to do that. Line 11 says, is that for me?
Yeah. You want to start wrapping up. You got something quick? Or?
Yeah, I understand. Line 10, something we don't do anyways. Line 11, something we don't do anyways. It would be unworkable. Line 12 talks about not requiring a specific format. There are formats required under levels higher than us to allow these things to communicate. I have a good friend whose mother is suffering from cancer, and hearing the stories about how the pharmacist and the oncologist and the radiologist and the primary care provider can all work together and see all the data in front of them is a very important benefit to this. So we certainly encourage people to use it. We like it when people use it, but we also understand New Hampshire is a rural state. There are a lot of small providers. There are a lot of specialty providers, people doing acupuncture and chiropractic. They're not going to be prescribing drugs. It's not going to be things that require the use of electronic medical records. So this bill, it's not something that's happening now. It's not needed. And if you implement it, especially lines 12 and 13, saying that you can't have requirements for how it works, that who's to say someone hires someone to build an electronic medical record for them that doesn't communicate with anybody else? That defeats the whole purpose of the EMR. So the bill as it stands is unworkable and really unnecessary because we're not the ones doing this. It's CMS that's doing it, and that's where the fight should be taken. Thank you. Happy to take any questions.
Any questions? Seeing none?
Thank you, Mr. Chair.
Thank you. No one else has signed up to speak on HB 70 FN. Does anyone else wish to speak? Seeing none, I'm going to close the public hearing on this bill, HB 70 FN. The next hearing will be at 10:30 on HB 731 FN, which is in about 5 minutes. So we'll be in recess until then.
Thanks for smiling.
sponsor on the bill. And this bill is just one small step we were hoping to take to help a particular type of housing for people with disabilities. And it's to clarify exemption from licensure. And we felt that the bill was needed to correct a misunderstanding in the way that bit of statute was interpreted. And as the bill now reads, without the bill, it's simply that one section A, facilities which are operated for the continuing care of one person or 3 or fewer persons in a facility certified by the Commissioner of Health and Human Services. And I'm going to talk about a little bit about one situation I know well to help you understand the certification for a place with just 3 people or fewer. And that's, I think it'll just help understand, because I found myself explaining this to other people. Because my stepdaughter lives in such a facility, which is a house, and she lives with her boyfriend. Both of them have Down syndrome, and they live with 2 home care providers. So there's no more than 2 clients under one roof. The healthcare providers are paid through community partners, and they provide oversight for the home care providers and support. And Eliza and Shane also receive services from other outside agencies, and they each have their own independent case manager. So in this case, the whole house does not need to be licensed. It's just certified by Health and Human Services for basic things to make sure it's a safe place for them to live. But there are drawbacks to this home care providership model, in that it tends not to be a permanent housing solution. Now, Eliza's lucky that my husband and I were able to buy a house and rehab it for this purpose. But most people with disabilities don't have a father who's a contractor who could pull that off. So because of the lack of permanent housing solutions for people with disabilities, there are a lot of parent-led groups across the state that are trying to set up new solutions, because many of the parents are getting older and they now have adult children still living with them with disabilities, and they're thinking, like, what's going to happen in the future for my child? We need to come up with some other solutions. And there are 2 concepts that are being pursued by several groups across the state. And one, the residents will live in separate apartments under the same roof or maybe separate buildings, but they share a common space. And the entity, which is typically a nonprofit formed by these parents, the entity would manage a facility and also hire staff. Some of them might be providing transportation or helping to prepare food, but they usually would have one person there 24/7. The other model would have a percentage of apartments set aside for people with disabilities, and say a new large apartment building that's being built through the Affordable Housing Fund, in which there could be workforce housing. A lot of people could live there, but 25% of the units would be set aside for a person with disabilities. And there may be 2 or up to 3 people sharing the apartment within this larger building. But the difference there is that the nonprofit may own the building, but they're not providing all these comprehensive services directly. There'll be an outside agency that is providing them. And they may provide meals or not, and may engage in other community activities, but the residents would still live independently. So those are the 2 models that we were hoping with this bill to try to clarify the statute so that ideally they might be exempt from licensure and only be certified. However, we amended the bill, which I brought forward to you, at the request of Doreen Shockley at Health and Human Services, who felt that the original bill was not accomplishing what we wanted it to do. And it was also probably not legal as well. So this is very disappointing for some of the people that we've been working with and trying to come up another solution, because it looks like it would only help the model of the apartment building in which no direct services are being provided by that nonprofit that got the thing built. Now, other people that are here might be able to explain some of this a little better, but I'm trying to sort of break it down to see what our goals were and what the bill can or cannot do. And it may be that we bring another amendment forward again before we exec the bill, because some people felt like we could have tweaked it a little more. We might actually making things harder than not better. And what else? And I would say, like, there's nothing, the first model that this bill or the amended bill, we'd like to help. It's a great model. And it might be, though it still might have to be licensed, even if we would like to say, oh, it could just be certified. But given the comprehensive nature of the services provided, and that it's all done by one entity in which the resident doesn't really have a choice about who's providing these services, they may have to be licensed. Maybe we can't fix that problem. We're still trying to work on it. But we hope that you will support the bill and we can try to come up with the best amendment to fix this problem by the time we have to exec it. And then we could move forward in a more, streamlined fashion. The other solution is that we could try to work on rulemaking so that if there's no way around having to be licensed, we can try to make licensure as least costly and easy to do as possible. So, and the other thing is we hope that you will support the bill and help these groups to overcome the biggest obstacle that they have, which is financing, but that's a matter for another bill before other committees. But just to keep that in mind. And that's it.
Thank you, Mr. Chair. Thank you for bringing this bill forward to us. I just have a quick question where it says such units shall meet certification standards established by. Can you just give like one or two examples of what would be involved in certifying these units?
The only one I can speak well was why I brought up the home care providership with where my stepdaughter lives. Well, they check to make sure the smoke detectors are current and are inspected annually. They make sure that the residents have regular fire drills. They make sure the place is a safe and secure home. That's most of what certification is in that situation. Yeah.
Other questions? Representative Kofal.
Thank you, Mr. Chairman. Thank you for taking my question. So I'm trying to understand the distinctions between the amendment and the original bill as filed. And I'm looking at the amendment at the moment. The bold italics say this exemption also applies to buildings that provide residences to both independent individuals and individuals receiving services pursuant to RSA 126A 19 and 20. It then says that it also applies to any entity that provides housing to three or more individuals receiving services pursuant to those sections, provided that the entity does not provide or arrange for personal assistance. So what I'm struggling with, I mean, generally I really like the idea of sort of dialing back and clarifying some of the regulations.
Yeah.
I'm just struggling to understand there's sort of a confusing mix of what would be exempt and what would not be exempt. And so both for my own edification and so that we have it clarified on record, should the courts ever need to look at this, it would be helpful to me to understand
almost like a matrix or a list of bullet points of which scenarios are exempted under this amendment and which are not. I'm more concerned about the amendment than I am with
Yeah.
the original bill, because I sort of assume that you're bringing forward the amendment with the intention of addressing the concerns that you raised. So do you have that kind of an analysis, or could you provide that kind of an analysis to us at some point following
Yes.
the hearing?
And you're not alone in feeling that way. Actually, and Doreen Shockley is here, who really helped draft the amendment, because when she looked at the original language, this isn't really going to work. It's not going to do what you want. But the best I understand it now is saying that, provide residence to both independent individuals and individuals receiving services pursuant to, and that's the other whole section about types of services provided to people with disabilities. So in that scenario, it's the apartment building where there are people that aren't getting any services, but say we have 25% set aside for people who are. But I think it's, and I did want to clarify with many of the stakeholders that, well, it can mean that you're still providing some community meals and movie night, game night, a lot of activities, but any specific like medical services or a personal assistant that helps someone that has mobility issues or transportation, they would have to be provided by another agency, not the entity that owns the building, is the difference. But we can try to break it down. And Doreen Shockley is also here if you want to ask her more specific questions.
All set? Any other questions? Representative McKay.
Thank you, Mr. Chairman. I'm very interested in this subject. However, there are all kinds of housing problems. There's mentally ill, there are people coming out of prison, there are people with developmental disabilities, there's all kinds of extremely needy populations. I'm trying to figure out how to not get these different groups competing with each other for services and have a united front. I'm a landlord who does have 4 apartments in my house, and I don't want to say too much because it would deal with people's identity, but there are very complicated problems for landlords who do try to help, so that what I'm saying to you just complicates the problem that you're bringing to us. But I think it needs to be considered because of this is a major state policy issue, and one that I'm hoping we can go at that deals with all of the issues. And do you have any thoughts along the lines of this kind of vague concern that I have?
So it sounds like you're saying, well, I provide housing for people that might qualify for special services provided by someone else. And are you wondering how much, to what extent will your property need to be certified for certain things?
I think it should be. I'm a licensed clinical social worker, and I deal all the time. Unfortunately, I've ended up in court because of it. But most landlords are not in that position that I'm in.
Well, I think the key thing to understand is why, in some circumstances, it should be okay just to have certification, is that many of the other people that are helping to provide services for these residents are licensed in their own field. They're licensed to practice what they do. And so it's trying to avoid having excessive licensure when it's not needed. So
The chairman won't let me go on, but that if he would, we could spend the whole afternoon.
I definitely don't want to do that.
Thank you, Mr. Chairman.
You're welcome. Any other questions? Seeing none. Thank you.
thanks.
Also signed up to speak is Representative Kathy Staub. Is it Staub or Stobe or
Staub,
Staub? Okay.
the German way. Thank you, Mr. Chairman, members of the committee. For the record, my name is Kathy Staub, and I'm a representative for Hillsborough District 25, which is Ward 5 in Manchester. Last year, I had the privilege to serve with the sponsor of this bill on the study committee on the impact of the housing crisis on people with disabilities. We learned that there was an overarching issue around the fact that most people with disabilities have limited income and there are not enough units that are affordable for them. However, we also learned that there were issues that were specific to the population with developmental disabilities. A few decades ago, we turned away from institutionalization for children with developmental disabilities. Instead, they lived with their families, attended their local public school, and grew up as part of their communities. As a result, we've learned what they are capable of. There continues to be a wide range of needs. Some need 24/7 care, but others hold jobs, volunteer, socialize, and are active contributors to their communities. Most of them continue to live with their parents who are aging, and that has the parents very concerned. The time has come for us to develop new models of housing for adults with developmental disabilities who need varying levels of support. The good news is that the parents have stepped up and are willing to use their own talents and resources to leverage available funds to create these new models of supportive housing. And this bill is the first step in removing some of the barriers that they have encountered, and I hope you will support this bill. I mean, for example, we've been talking about this mixed development. There is a specific rule that refers to people with developmental disabilities, saying that no more than 3 people with developmental disabilities can be under one roof. So what that means is if you have a 20-unit apartment building and you set aside 5 of those units for people with developmental disabilities, even though there's only 1 or 2 people living in each one of those apartments, that would mean that the entire building would need to be licensed, which means the owner would have to fill out reams of paperwork. They would need an elevator that would support a hospital gurney. And so the cost of the development of the building would be higher, and the level of paperwork and other things that would be required to maintain the building would also be increased. And you know, for you know, this is really low-hanging fruit here, is to just kind of remove that distinction so that we can create these mixed communities where people with developmental disabilities can live in the community, have access to transportation and amenities and services, but not force their landlord to have to fill out reams of paperwork and develop, all the building really as some kind of a healthcare facility. So that's why we're looking at this. It's just one little thing.
Sure. Any questions? Representative Polozov.
Thank you, Mr. Chair, and thank you for taking my question. So 2 parts. Like, first, to follow up on Representative Kofalt question, if there would be a further amendment to this bill, I also would like to see some clear list to understand, like, like in amendment, I'm not sure if we are talking about 2 types or 3 types of facilities or 4 types, so some list would be helpful. And a question is, you mentioned affordability. So do you have any estimate of this licensing cost burden, how much it adds?
I do not. There are folks who have been working on developing these kinds of facilities or these kinds of buildings or housing developments who will come after me, who have been investigating this in more detail. I will send everyone the preliminary report from our committee so you can see what kinds of information we uncovered when we talked to folks. So I do not have that information. And in terms of the cost burden, we did hear about it. In terms of the amendment, we have been working with Doreen Shockley, and I think that she may come forward with some ideas of how to clarify that. But basically, the idea is that, if you're living in your own apartment and you're bringing in outside agencies to to provide services for you, whether it's you need help with taking your medications or you need help with cleaning or whatever, if that's being done with an outside agency, then that's one class of housing that will be available, and that's what this bill is looking at. Whereas the more complicated one is the more, let's call it all-inclusive, where you're living in the building and all of the services that you need are being provided by the owner of the building. So that's more complicated, and Doreen Shockley can probably provide more background into how complicated it would be. A lot of this, these rules come to us from CMS, and we don't want people to be in violation of the rules that are coming from CMS about people with developmental disabilities when they're trying to provide housing for people. They're young, they have jobs, they have lives, they just want to continue, and their parents want to make sure that once their parents are gone, that they're in safe and stable housing, so that they're not gonna, they want what we want for our kids. We want them to be safe, we want them to be happy, and that's what we're hoping to accomplish with making this small change to really kind of pick off this low-hanging fruit that's preventing people from building appropriate housing for adults with developmental disabilities.
Okay, thank you. Any other questions? Seeing none, thank you.
Thank you.
Also signed up to speak is Laurie McIntosh from Our Place, New Hampshire.
Thank you, Mr. Chairman and members of the committee, for letting me speak this morning. I did not bring enough copies, so I promise I will email you all my testimony. My name is Laurie McIntosh. I'm from Dover, New Hampshire. I'm the chair of the board of directors of Our Place NH. It's a nonprofit organization with a mission to provide housing for adults with intellectual developmental disabilities, or IDD. Our Place NH has purchased property in Dover, New Hampshire, and is planning to build supportive housing apartments for 11 individuals with IDD. I'm speaking in favor of House Bill 731, which would make it possible for a new model of housing for adults with IDD to be created in New Hampshire. And I want to shout out a big thank you to the committee that worked on this, the committee to study the impact of the housing crisis on people with disabilities, and the staff members from DHHS who have worked with them also. Our Place New Hampshire has been working with a developer from New York, and Jessica talked about this already a little bit. He's created large workforce housing apartment projects with 40 to 50 units, and he reserves 25% of the units for adults with IDD. Within each project, there's a common area where all tenants are invited for activities such as art classes, movie nights, and yoga. This is a great way to facilitate the inclusion of individuals with IDD. The project also provides offices for service providers within the building. The tenants with IDD have 24/7 staffing, and the services are provided to those who choose to have their services delivered by the agency in the building. House Bill 731 would help make this type of project possible in New Hampshire by amending RSA 151:2 and allowing the individual units to be certified for provision of services to this population rather than requiring licensing of the entire building. This sensible change will make it much more cost effective for the developer. There is some language in the amendment to this bill that I hope will be changed before it goes to executive session, as the wording implies that the tenants would have to be on participant-directed managed services, which is, you'll have to learn about that, but there's different types of services in New Hampshire. And the amendment implies that people will have be self-directed. And that is not how the model that I'm looking at works. So there is another model of budget use, which is called the HEM 1001 budgets. And in those budgets, you can combine services. So for instance, if you have 10 people living together, they all pay 1/10 of the overnight staff. So you have to be able to use these Medicaid budgets that are combinable. Anyway, HB 731 is a step in the right direction. I'm disappointed that this bill does not make it easier for some of the smaller projects like ours that are existing or proposed, because we're going to have to jump through the hurdles of licensing. But as someone else said ahead of me, maybe the appropriate way to go is to work on those licensing requirements to make them a little easier for projects like us. So please pass this bill, and I'm ready to take any questions.
Okay, thank you. Any questions? Representative Palazzo.
Thank you, Mr. Chair. Thank you for taking my question. Could you speak a little bit about those licensing requirements, what they are they add to safety, and what is the estimated cost of complying with those requirements?
Okay, well, because we have not actually developed our project yet, I can't give you exact numbers, but I can tell you that when you have to go through licensure, there are a little more stringent demands for, fire safety things, but not much. We have to have a sprinkler system. I know that. But there are some things that were mentioned before, like having to have an elevator, some of the licensure requirements, like in a healthcare facility, you have to have toilets that can hold up an 800-pound person. Many of these things, could be waived. So working on the actual licensure rules themselves might be able to pare down some of those expenses. The other thing is that licensure requires more documentation. So not only do you have to clean your stove hoods over the stove every month to make sure that the grease isn't there, but you have to have a notebook with a chart in it that shows that you've cleaned those stove hoods. So somebody has to be in charge of that. So there's a lot more documentation required for licensure, and that requires more staff.
Other questions? Seeing none. Okay, thank you. Also signed up to speak is Doreen Shockley from the Department of Health and Human Services. I've been hearing a lot about you from previous speakers. So.
Good morning, Chairman McDonald, committee members. Having heard my name over 6 times, I thought it might be a good idea to come up. I hadn't planned on testifying, but I do appreciate this opportunity very much this morning. And as has been said, I've worked very closely with stakeholders across the state, as well as the committee. I want to spend very brief time, but I do want to let you know that this conversation, and if you're feeling that this is complex and difficult to kind of grasp, it is. I've been working on it with folks in the community since December of 2022. So that gives you some information as to how long this conversation has been going on. It was in 2023 that Lori and her team came forward with a model that they wanted to use in Dover. You've heard about that this morning, 25% independent folks, and then some, or just the opposite, 25% are those that are going to be receiving services, and the rest would be independent. And as the law is written now, we would be required to license that facility, that resident. I encouraged them at that time to seek a sponsor to change the law, because it's certainly not something the department wants to have regulatory oversight on a place where there's a mixed use of. So that's why we're here today. I've heard a couple comments about the bill as originally written, and as originally written, if you would look at line 9, leasable unit providing complete and independent living facilities. Well, those don't need to be licensed now. So this bill was, in fact, accomplishing nothing in terms of this population, which is why I then reached out to the committee and said, okay, so based on the feedback that we've received through all the sessions, this is not accomplishing what was originally intended. Therefore, I made some suggestions to the language, which is what you're looking at in the amendment. I do understand there were conversations last night in terms of maybe providing a little bit more clarity, which we are certainly willing to do in terms of, it is our position that this does, in fact, it's a small step, but it's also a big step. I know that doesn't make sense, but having worked on this for close to 3 years, I'm excited to see that we are going to make some changes. I hope that we can amend the language somewhat. We have more work to do. Unfortunately, this committee is engaged for another year, which is not ordinary. It's usually 1 year, and we have 2 years. And I've already spoken to the State Fire Marshal's office this morning. They are willing to engage in conversations to carve out more of the larger environments that may also want to be exempt. That we don't want to do that now because it will have unintended consequences. But once we engage with local authorities and State Fire Marshal's office, we might be able to exempt additional. I think that's all I have. Do you have any questions?
Thank you. Any questions? Representative McKay.
Thank you, Mr. Chairman. Since you're from the Department of Health and Human Services, I'm going to try again. So there's no confusion, I support this legislation. However, it's a larger problem than the one that's addressed in this legislation. And it's a major issue for our state. There's no question about it in terms of housing. Is there some way that the department, through the Oversight Committee, could begin to look at this in a more comprehensive way? What I'm concerned about is one group competing against another, and what we could have, which would be a powerful issue, would be support coming from all of these different groups who are in Concord. We have a very serious housing problem, and we just recently shut down one of the biggest homeless aspects in our city, and where those people go is beyond me. So I would, as much as I support this, I support a larger concept that deals with all of the aspects of our housing issue. Do you have any comments?
Thank you, Representative McKay. I failed to introduce myself. I am the manager of the Bureau of Licensing and Certification at the department, and I think it's important, and you raise a very important point, and I appreciate that. I think it's important to note that the population of individuals that we're speaking about today are already in the system at the department in terms of the Bureau of Developmental Services. They're already receiving services, and we also certify the housing, which I think Representative Lamontagne described. There's a certification process, and then there's a licensing process. In terms of a more comprehensive way to deal with our housing crisis, I think I certainly would believe that the department would be certainly supportive of that. I don't know if is there a committee that's working on that? I don't know. I think Representative Missouri is saying yes. I would imagine that there is a committee. I would be happy to contribute to that to the extent that my bureau would would have an impact on that. I know this committee was focused primarily on those with disabilities and how the housing crisis was impacting that population of individuals. I hope that answers your question.
Thank you.
Representative Polozov and then Representative Woods.
Thank you, Mr. Chair. If you could go through the list and just help understand what I counted 4 types of facilities here, and second one is 3 or fewer that are certified, but then line 9 talks about 3 or more individuals. So I'm not sure if third type and fourth type mentioned, are they certified? So if you could just quickly go what kind of facilities this bill affect in terms of a list.
Thank you. So if I understand, you want me to describe what the amended bill is accomplishing? Okay. First, the bill would amend RSA 151:2 Roman 2A by adding a license exemption for buildings that provide residences to both independent individuals and individuals receiving services. This is important for the state of New Hampshire because there are already, as we've heard, structures that fall within this definition, like apartment-like structures. And currently, those are requiring licensure, so this bill would change that. Secondly, the bill would amend RSA 151:2 Roman 2A by adding another license exemption to any entity that provides housing to 3 or more individuals receiving services, provided that the entity does not provide or arrange for those personal assistance or any health-related. It creates an exemption for entities that are providing housing to 3 or more people, but the individuals are managing their own services. This, I believe, is language that last night in a discussion was, there was some concern that the way that the language that I suggested may be prohibitive. So I think there was some suggested language that the department would absolutely consider. Our goal is to help increase the exemptions so that there's more opportunities, not diminish those.
Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. The original bill had no fiscal impact. From what you've described and what you anticipate some changes, could you comment on the fiscal impact in general? Obviously, you can't give details, but would that change dramatically or not?
Thank you for the question, Representative Woods. The original as written bill had no impact because it didn't accomplish anything. I shouldn't say it didn't accomplish anything. Sorry, that was not what I meant. I meant they're already exempt, so it had no impact. I don't really see the second with the amendment will also, if anything, it would, so I have 2 teams. Well, I have more than 2 teams, but 2 teams that would be impacted by this bill, a licensing team and the certification team. The certification team is already working with all of these types of entities. The change would be that licensing would not be. So if anything, there would be less fiscal impact to the department, not more.
Other questions? Seeing no other questions, thank you.
Thank you.
No one else has signed up to testify on HB 731FN. Does anyone else wish to testify? If there is no one, then I'm going to close the public hearing on this bill. Again, HB 731FN. I'm going to close the public hearing. We will be in recess until 11:30, at which time we'll be hearing HB 117. Hello, everyone, and welcome back to the House Committee on Health and Human Services and Elderly Affairs. The next bill scheduled to be heard today is House Bill 117. Prime sponsor is Representative Erica Leon from Rockingham County District 13. Welcome, Representative Leon.
Thank you, Mr. Chairman and members of the committee, and hello again to all of you I've served with in this committee in the past. I am here to introduce House Bill 117, which was originally brought forward by another former member of this committee, Representative Gary Merchant. He is a pharmacist and was a former chair of the New Hampshire Board of Pharmacy and a very knowledgeable man in this area. This bill is actually a lot more simple than it seems. Right now, there may be some movement in Washington, D.C. and the FDA to recognize what other areas have always realized, that there's not really a difference between interchangeable and biosimilar, other than a regulatory pathway that provides some protection for the first entrant into the market. When you have we have some other people here that can talk to a lot of the science on the biologics and biosimilars, so I'm just going to stay on the very, very top level of this. Basically, biologics we're talking about large molecules, not little small molecules like aspirin. And we're talking about things that are grown and not produced in a chemistry set. So it's a different process than generic drugs, generic small molecules. And the biosimilars are similar, but not exactly the same as generics. So back when I was an analyst covering some of the big companies that make drugs like Humira, I was kind of worried for investors about what was going to happen with these biosimilars. There was a program that came around that said that when you have one of these drugs, you go and you do a pretty big test and you switch people back and forth just to make sure that they're not any different. The thing is, in order for a biosimilar to be approved at all, you need to do a lot of tests that show that you statistically can't find a difference between the original biologic and the new biosimilar. This is a process that's been going on for nearly 2 decades. And in Europe, there was never a difference between interchangeable and biosimilars. And there's been quite a good deal of guidance saying that there's not a difference between interchangeable and biosimilar except in the U.S. regulatory scheme. And I can send quite a bit of information to anybody who really wants to get into the details on this, but I also didn't want to flood you with papers. So at this point, there's been some draft guidance circulated by the FDA that may sort of change the way that interchangeable drugs and interchangeable biosimilars are treated. We don't know when they'll act on it because unlike the state of New Hampshire, the federal government doesn't set time limits on when they need to act on recommendations. You know, it'd be a better world if they did, but not everybody can govern like Concord does. So if the FDA decides that you no longer need to have a switching study in order to substitute biologics, it wouldn't meet our current definition of interchangeable products. In the bill in front of you on line, I don't have line numbers on mine, but in section 3, that would allow that if the FDA adopts another way to have what is in essence interchangeable biologic, that would allow the New Hampshire law to adapt alongside with the FDA's changes, because right now our language could lightly lock us in and leave us behind the times. And this matters a lot for our constituents. I was actually talking to one of my neighbors who is a great guy. I didn't really think I was going to get into the science of biologics with him, but he was telling me about how life-changing some of these drugs are for him and how expensive they are and how the biosimilars have made a significant difference in his life by being able to not pay the branded price. If we adopt this, and if the FDA makes the moves needed so that this actually becomes effective for us here in New Hampshire, this would mean that if you show up and you have the original drug, the Gucci one, whatever the fancy one is, that costs $1,000 a month. You have the biosimilar that your doctor wrote you a prescription for, which is biosimilar A, that costs you $600 a month. And if your pharmacist can get you biosimilar B, which right now only costs you $200 a month or $400 a month. The pharmacist can talk with you and say, these are going to be no different in your body. When we've tested them, they're no different. They're not provably different, and they're no different than different runs would be of the biologic. So we can do this, and if you want to save this amount of money, we can switch you and there's not going to be a difference in your treatment, because by definition, a biosimilar has that same effect. So this would really empower pharmacists to help our constituents save money at a time when we're all struggling. And this wouldn't move ahead of the FDA. It would just allow us to sort of draft right along them. If they change these requirements, we can follow right along and implement it as soon as they do that, make that move. And so I think the biggest part too is you may end up hearing about some harms from biosimilars. There's a great reporting program, 1-800-BAD-DRUG. If somebody tells you that somebody was harmed by a biosimilar, the first question you should ask is, when did you report this to the FDA? You can call 1-800-BAD-DRUG. If somebody hasn't reported it, but they're telling you about a bad event, a bad outcome, I would question that, because if there's really a problem, the first people they should call is the regulators to help keep patients safe. Secondly, the FTC and the FDA are working together to make sure that there's not misinformation on biological products. You may end up hearing from people about something called a nocebo. It's like a placebo, but people are very afraid that when they change from blue to red, there's going to be a noticeable difference when there's not. When people who should know better feed into that, it's a problem. And the FTC has said that that may be anti-competitive in order to spread doubt and concern about the clinical efficacy of these drugs. So when I reviewed the comments on the FDA, the potential change in FDA guidance, where all you would need to do is scientifically prove that they're the same without having to put them through people and change them, because at this point the science is there. There were 28 people 28 organizations or people that provided information. A lot of the very high-level scientific and medical organizations like the American Medical Association and the American Society for Clinical Oncology support the change, because they understand the science, that we know with the tests that we now have available that weren't available 15 years ago when this first happened. They know that it's not going to have a difference in the human body, and it's not going to make a medical difference for patients. It'll just make a financial difference, because if you can't afford your drug, that could have life-ending consequences for you. There's different organizations. A lot of this is why the FTC is working with the FDA to make sure that the information that's presented is clear and convincing and doesn't lead into fear and concern when it should not exist. Because goodness knows there's enough things we need to worry about in this world. We don't need to add non-problems to worry about. So with this, I would ask for your support of this bill, because it allows us to move along with medical and regulatory innovation at the federal level when it comes forward. And it's the right thing to do to impact financial toxicity. So I'm ready for any questions.
Thank you. Representative Weber.
Thank you, Mr. Chairman. Thank you for bringing the bill to us, and thank you for taking my question. And I'm just noticing on page 2, this also includes a patient prerogative sentence. So if the patient informs the pharmacist that he or she doesn't wish to receive an interchangeable biological product, they don't have to. They can go with the original. And so it's up to the patient to make the trade-off between the price, how they feel, whatever else is going on.
Correct.
Thank you.
Correct. And that may also lead to a patient deciding that even if the one that's been prescribed isn't available, they'd rather just wait or find a different pharmacy, because that's their right. But if they wanted to change, they'd be able to.
Okay, thank you.
Other questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So bear with me, because I'm still trying to understand. So, and I'm reading, like you said, lines 22 to 24. So is the FDA working on that already? And what exactly is the nature of the change that they would just say, we're going to license this biological, but we're not going to say it's interchangeable? Who is going to make that determination that it meets the definition of an interchangeable? I'm just trying to kind of, where's the definition coming from? If it's not, you know what I'm saying? So if you could
Yes.
just clarify, and if they are working on it, how imminent do you believe it is?
Thank you for the question. So there are several different moving pieces. Back in 2009, they had the original legislation that allowed for the biosimilars and allowed for some of the transparency around it. And when the FDA implemented this, where if you had the copy molecule or the copy biologic, and you did a switching study on patients. If you ran that, did the switching study, and submitted for an interchangeable designation, nobody else could come up on your heels and bring another biosimilar to market for a whole year. So you had 1 year market exclusivity, which would help cover the cost that it's really expensive to run these trials. At the time, too, they didn't have the capabilities to analyze these outside of humans and do the assays to make sure with enough confidence to satisfy the FDA that these really did act in the same way. So in the meantime, there's been advances in the way that they can assay these and assess them outside of humans. There's been movement. Senator Mike Lee has introduced legislation on this, and there's been bipartisan support in order to do this. I want to note that the only other legislation that I'm aware of on biosimilars was when Senator Hassan actually put one in about more education to make sure that people are appropriately educated on biosimilars and the options and the fact and about their safety and about the equivalency. So the FDA has done several efforts to do this. Right now, they're talking about the labels, and the labels, they don't want to have a big distinction between an interchangeable label and a biosimilar label, because that difference in designation is causing a lot of that hesitation, and it's causing people to perceive that they're having a different outcome just because they've gone from red to blue. They're working on some of the delivery mechanisms because some of these are shots, and they're working to standardize this. So there's a lot of different efforts within the FDA in order to move past this transition phase where we had interchangeable biologics and move to where the rest of the world is, where a biosimilar is a biosimilar is a biosimilar. The European medical agencies and the health leaders of Europe have also put out a paper trying to deal with the confusion around interchangeables and biosimilars, because while interchangeables are a uniquely U.S. creation, the concern that's been raised about the difference between them has actually led to a lot of patient confusion, even in Europe. So once the FDA is able to move past this and move past this hurdle where they required more very, very expensive tests in order to get market exclusivity that then also allows you to sell that one for more money than you would if everybody and their brother was introducing a biosimilar, this is going to really, really reduce costs. There's now over 60 biosimilars that have been approved in the U.S. When this bill was in front of Commerce last year, there were only 49. So this is something that is absolutely exploding, and it's being done. It's being done in a way that doesn't negatively impact patients' health. So this is a little bit old. It's from March 2020. But back then, biological products were only 2% of prescriptions, but they accounted for 42% of the total net spending on prescription drugs in the U.S., which was up from 30% in 2014. And at the time, one of the panelists was stating that about 40% of new drugs are biological products, with 60% being the small molecule, what you call a traditional drug. So biologics really are advancing medicine for us. These biosimilars are, and the FDA, they don't have a time frame. When speaking with some of the industry lobbyists that have spoken with the lobbyists in DC, the FDA doesn't have to act on their draft guidance at any point in time. I had thought that if this was going to come in the summer, then maybe we hold on to it and wait and do it after that. But we don't know when the FDA will act. But if we pass this, we're ready and we're poised and able to take advantage of that change without moving ahead of them.
Follow up?
just a quick follow-up because I'm really trying to understand. So it sounds like that they have, they're loosening up on the testing methodologies that would allow you to no, he's shaking his head. So I'm just trying to understand. So but they're allowing for more streamlined testing, and also they're eliminating, basically, you're the first guy, you have kind of the monopoly on it. But it sounds like, from what you're saying, if I understand correctly, they're still licensing, though, right? And so if they're still licensing, if I read the language in here, you're just taking out being licensed by the FDA as an interchangeable biological product. So, but they're still doing the licensing. It's just that they're altering certain methodologies and certain prohibitions. So I don't understand what this change of language is doing really. And it's probably just, I'm just not putting the pieces of the puzzle together yet.
Thank you for that question. It's because they took that intermediate step of these interchangeable. We don't know exactly how they're going to change the language for the interchangeable. So that's why it's written the way that it is, so that when they determine that something is equivalent to an interchangeable, this sort of mushy language would allow us to recognize that the FDA has recognized this as as essentially the same as interchangeable. Therefore, state law will as well.
Thank you.
You're welcome.
Other questions? Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. Drilling down a little bit, you may not be able to answer the question, but what are the details about the loosening of the, I'll use that term perhaps improperly, the change in testing that's different with the biologic versus a new drug that comes out, which has really internationally one of the more rigorous testing programs, and that's to our detriment in general. What is that difference? Harking back to the history with penicillin, when we found out that people were really allergic to it, but it wasn't penicillin, it was the moiety that it was vehicle carrying the penicillin that was the problem. So there's subtle changes that can be dramatically, even though. So what is the difference in the testing that? You may not know the details, but some concern.
So I can hit the surface on this. My husband's actually been involved in biomedical research for over 30 years, and he is intimately involved in that process for bringing biologics and biosimilars to market. So he'll be able to give you more details than I.
He's next.
He's here. I know that there's also companies that have been pioneers in this area who are here as well. So there's going to be a lot of good scientific knowledge. But what they're removing is the in-person switching studies, because now they have more. And when they're assessing these, you're not just looking at a little stick that says yes, it's the same, no, it's not. It's a lot more highly involved than that. But other people can speak to that more. And worldwide, there have not been unique adverse events from a biosimilar that is different than the adverse events from the reference molecule. So there's risks, but they're the same risks as the original one.
Other questions? Seeing no other questions. Thank you.
Thank you.
Also signed up to speak is Christopher Kent from Amgen.
Good afternoon, Mr. Chairman, members of the committee. My name is Chris Kent. I work as part of Amgen State Government Affairs covering New England. A little bit of background about Amgen, the company that I work for. We are a biotechnology company backed by 4 decades of experience with the research, development, and manufacturing of innovator and biosimilar drugs. We currently have 11 biosimilar products in our portfolio. Half of them are marketed, and then the other half are in development currently. And we have substantial ongoing investments in biosimilar research and development. I just kind of wanted to talk about this bill. So last year in the House Commerce and Consumer Affairs Committee, I sat up here and opposed the legislation. And currently we we still oppose the legislation for a number of reasons, and it really has to do with patient safety and dosing. That's what it comes down to in the end. If you kind of boil everything down, I'm the way that I originally read this, the intent was to follow on the bill last year, but it's sounding like that this bill, the intent of it is to have a law in place or a statute in place that would follow any type of actions at the federal level or if FDA takes it. I really don't think at this point the bill is needed for a number of reasons. First and foremost, we believe that the interchangeable designation is an important one. And just as a quick, and I'm going to try to keep this as brief as possible, but back in June of 2018, there was a law that passed in New Hampshire and all 50 states. It's called the Pharmacy Substitution Act. And the current law, as passed in June of 18 in New Hampshire, and all the other 50 states have it. It permits a pharmacist to dispense an interchangeable biosimilar product only when the brand reference product has been prescribed. Once a substitution has been made, a pharmacist has 3 days to communicate back to the physician that a substitution was made. In our view, this law is working very well. And we don't see a need at this time to make any changes to the law, including passing this legislation, which, in the end, I'm not sure the way that we read it, I don't think it really does too much, to be honest. But what this legislation, again, as the way that we look at it, it would allow a pharmacist to substitute one designated interchangeable for another designated interchangeable. But I'm learning that maybe that, my reading of the bill might be incorrect. But again, we think that the current law is working well. And then there was a couple of questions I wanted to also talk about. When Representative Weber, I think you had asked about a patient declining a substitution. So if you think about it, a lot of these folks that are taking these biologic medicines are really sick, grievously ill, chronically ill. Folks that might be might be in the right mindset to make a decision about if a pharmacist is asking them about a substitution. Also, a lot of times family members or caregivers will be there to pick up the prescription as well, and they might not necessarily know to say something. If we were to pass something like this in New Hampshire, it would make New Hampshire a complete outlier. This bill has not been introduced anywhere in the entire country. I don't know of any other state that's considering this. And again, this would make New Hampshire a complete outlier in doing this. Another thing that I just kind of wanted to talk about is if it was the refuse. Yeah. But yeah, I mean, that's there's the timer. Yeah, I knew my time was coming up, but we oppose this. I don't think that this is necessarily needed to be passed at this time, and I'm happy to take any questions.
Thank you. Any questions? Wow. Covered it well.
Thank you.
I don't see any questions, so thank you. Also signed up to speak is Jason Azis from the New Hampshire Insurance Department.
Good morning, Mr. Chair. For the record, my name is Jason Azis, Director of Health Economics, New Hampshire Insurance Department. I also sit on New Hampshire's Prescription Drug Affordability Board. Last year, the Insurance Department spoke on behalf of Representative Merchant's bill. Yes, so last year we supported the passage of this bill when Representative Merchant sponsored it, and this year the Insurance Department is also in support of this bill. I think one thing that Commissioner Betancourt feels importantly about is competition and providing our citizens with lower cost alternatives to expensive branded biologic drugs, and we feel that this bill is a step, albeit an incremental step, in that direction. So we are in support of this bill, and we'll keep my testimony short. So if anybody has any questions, happy to answer them. Thank you.
Thank you. Any questions? Seeing no questions. Oh, Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So from insurance department point of view, like if things if things go sideways, if there are some problems with some alternatives and some concentrations, as we heard, and if there will be some, I don't know, side effects or damage to patients, how would it play with your department? Will you see some effects? If you could speak to it.
Yeah, so adverse drug events, I think, is common vernacular for side effects. That's a good question. It's complex. I think our central concern is the financing of expensive but important pharmacologic therapies. And we noted in the 2023 New Hampshire PDAB annual report that when you have a branded biologic market that has no competition, that prices are about 230% higher compared to biologic markets for which biosimilars have been introduced. So we noticed an erosion of the branded biologic markets once the biosimilars entered. We used the example was Remicade, infliximab, and all three of the biosimilars for Remicade were also infliximab. They were just different isomerized versions of them, if that's the right term. So as far as adverse drug events, I think it's very different compared to the small molecule and generic paradigm versus the biologic and biosimilar. They're essentially the same substances, just different isoforms of them. So that's the limits of my knowledge on that. But cost is a big, cost exerts great harm to people. So if they're paying 2 to 3 times as much for the same therapies, by definition and by the construct of the social ecological model, that also is an adverse effect on people's well-being. And that's the lens that we have in the insurance department, who insurance finances healthcare delivery to our society. And so that's an important central theme of our interest in this bill. Thank you for the question.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So we went through some of the language of licensure, FDA, not FDA, but the gentleman from Amgen, when he testified, he said, and I'm trying to recall everything, drinking a lot, that in 2018, the rules were that pharmacists, if the doctor wrote a script, could prescribe an alternative, or they could on their own, but they had to notify the physician within 3 days. So I'm just looking at changes. I don't see anything of that in the italicized portion of this bill. So can you speak about the role of the pharmacist with this bill? How does this bill deviate from the 2018 law with respect to the role of the pharmacist?
It was my understanding from Representative Merchant that this gives the pharmacist a little bit more flexibility if the interchangeability status was augmented, or the barrier for interchangeability status was reduced. Then at the point of sale, the pharmacist would have more flexibility changing that out for the patient. And that's the limit of my knowledge on that.
Right. So maybe I'll save some follow-up for the next speaker then. Thank you very much.
Thank you for your question.
Other questions? Seeing none. Okay, thank you
so much.
Also signed up to speak is Dr. Michael Leon.
Good morning, members of the committee. Thank you kindly for allowing me to testify this morning. My name's Michael Leon. Yes, it's Dr. Leon. Michael's also 7 letters. I prefer Michael, but be that as it may, my training is as a pharmacologist right here in New Hampshire. Proud to say I did my training at Dartmouth. I've been doing biomedical research since the late 80s. Not quite 40 years, but it's getting mighty close. I'm hoping in just a few minutes to be able to communicate a few things to this committee. A, what is a biologic? I know last year the Commerce Committee deserves a lot of thanks, especially Chairman Hunt, who actually changed this position after looking at the data. Biologics aren't that complicated. If you want to dig into them, I'd be happy to provide anyone on this committee a link. There's a 2-text book. They're about this thick on biosimilars. You must like a lot of coffee if you're going to get through those. They're dense. Biologics themselves are quite easy. They've been around a long time. In fact, Amgen, who I used to work for 13 years, one of their products called Neupogen or filgrastim causes the body to make more white blood cells, a specific type of white blood cell. I belong to the American Society of Clinical Oncology, which called this one of the biggest breakthroughs of the last century. This biologic basically transformed the lives of cancer patients from having to be hospitalized when the majority of chemotherapies would suppress a patient's immune system to the point if you get an infection which manifests as a fever, it's called febrile neutropenia, it becomes a medical emergency. A simple injection in the arm, I hate needles, but simple injection in the arm can be given elsewhere, would help patients produce more of these neutrophils, potentially preventing infections. This was overwhelming, successful for patients that they were able to receive their chemotherapy and go home and be with their family. More drugs came along. They were small molecules that got rid of the chemotherapy, the nausea and vomiting. But needless to say, biologics within the field of oncology have been transformative. It is not their biggest use. If you know anyone who has something like MS, Crohn's disease, psoriasis, either of the forms of psoriasis, you may know someone else with something, a non-malignant hematology condition called I'll just call it ITP. People produce antibodies against their own platelets. There are biologics that treat these. Every drug has side effects, though. One of the first biologics, I grew up in San Diego, a place called the Scripps Research Institute. It's owned by MD Anderson out of Texas now, was developing an antibody. We used to make them in mice. Patient with cancer was given an antibody from mice. Absolutely amazing results on the first infusion. Unfortunately, the second infusion, that patient died because while the antibody had worked, it had gone in and attacked cancer cells. That patient's body, I will wrap up, the patient's body saw the antibody as a foreign entity and developed antibodies against it. This is where the previous concern about interchangeability originated from in the US. That was a purely mirroring mouse antibody. Antibodies now are engineered that they're fully human. You can take an antibody and put it into any person in this room. I hope none of you need them, but if you do, you can rest assured they are now made fully, the vast majority are fully human, that your body wouldn't recognize them. Our immune systems are complex, biologics are not. In a nutshell, aspirin, small molecules are made in a test tube, if you will. They're made by chemicals. They are exact copies of the reference product. The copies are exact copies. Biosimilars, biologic drugs are made in a living system. They're made in cells now. If any of you have ever been to a brewery or grow hydroponics in big vats, that's exactly how cells are grown now. Happy to chat offline anytime about it. I'm a scientist. I get excited about this. However, even a single company's product from today, think of a baker. If you bake cookies today and you bake cookies tomorrow, same recipe, they're going to be slightly different. In order for a biologic to be approved, the FDA, the company manufacturing it, and in the case of biosimilar, the competitors do preclinical testing. So they look at it on a lab bench, if you will.
If you could start wrapping up, please.
Okay, yep. There are, at that point, differences. You look at animal testing, there are not differences there that can be detected. They wouldn't be considered biosimilar. And then the gold standard is clinical testing. In clinical testing, there cannot be any distinguishing. They're indistinguishable, whether you have a biosimilar or the original biologic. And by indistinguishable, I mean both safety and efficacy. If you can't distinguish them, having something that's interchangeable, doing more testing, they can't be more indistinguishable if you can't distinguish them in the first place.
Okay. Thank you.
So, thank you.
Thank you. Any questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So again, I'm just looking, some of the stuff is italicized, but some of the stuff around the role of the pharmacist, it doesn't appear like it all is. So if you're aware, I want to understand the role of the pharmacist and how it changes if this bill passes.
Absolutely. So I think in a nutshell, that bill that you're looking at biosimilar also has to have the additional designation, which exists only in the US, nowhere else in the world, of being interchangeable. It would remove that interchangeable and allow a biosimilar that's not considered interchangeable. It's still indistinguishable, then for a pharmacist to substitute it. But if I can clear for a pharmacist, I used to work with Representative Merchant clinically. We never chatted politics. Pharmacists are underappreciated heroes in our healthcare system. They not only help with prescriptions of drugs. I was actually saved from a prescription of penicillin. I'm deadly allergic to it by a pharmacist. They also have to balance books. And if you're, pick your favorite hospital, or least favorite if you want, when they choose to have a particular drug on what they call a formulary, it's their list of drugs that they're going to keep, they may have the originator molecule. They're only probably going to pick one biosimilar. They're not likely to pick multiple biosimilars. So if someone comes up here from Florida, we're just about to hit spring, or vice versa, someone moves, they move a healthcare system, they just change pharmacies. Whatever it might be, they may be offered a different biosimilar. And right now, this would allow someone to switch from one biosimilar to the other without having to invoke the originator molecule nor an interchangeable.
Follow up.
Yes, thank you. Now, so I got that part, but if this was to pass, this bill, as I'm trying to read it, does that, even if the FDA doesn't change its rules, okay, which we've been talking about, does the pharmacist still have that kind of latitude in this bill, or no, it is contingent on the FDA rule change?
I believe in my reading, it is contingent upon the FDA rule change, because right now they are restricted to interchangeables only, which is an additional designation that exists only in the US.
Thank you very much.
Other questions? Seeing none? Okay,
Awesome.
thank you.
Thank you kindly.
No one else has signed up to speak on this bill. Does anyone else wish to speak on HB 117? If not, I'm going to close this public hearing. The next public hearing is scheduled for 1 p.m. on HCR 7. We're in recess until then.
I made those when you. Oh.
Okay, good. All right.
Good afternoon, everyone. I am going to start the public hearing for HCR 7. Representative or Chair McDonald will be here in a few minutes, so I'm just sitting in his place for a bit. So I'd like to recognize Representative Alexa Simpson, the prime sponsor of the bill.
Thank you. Good to see you. Good to be here. Good afternoon, everybody. Chairwoman Mazur. Is that how you say your
Mazur?
name? Mazur.
Yes.
Mazur.
Yep.
Great. And committee members. I'm proud to introduce HCR 7 today, which is a simple and straightforward resolution that allows our constituents to clearly see where the New Hampshire House stands on the right to abortion before 24 weeks of pregnancy. I've heard from so many of my constituents that they do not want any further restrictions on abortion in New Hampshire, and I know many of my colleagues have heard the same as well. We know that a supermajority of Granite Staters want their lawmakers to take proactive action on abortion rights in New Hampshire. New Hampshire is the only state in New England that doesn't have the right to abortion clearly spelled out in their state law or our state constitution. This lack of clarity is confusing for voters, and it's our job as lawmakers to be clear. What HCR 7 does is clearly show our constituents that our House position on abortion, that an individual's ability to access abortion before 20 weeks of pregnancy shall not be denied or infringed upon by the government. We saw how important abortion was in the 2024 election. Legislators, lawmakers, so many of us running for office promised on the campaign trail to not further restrict abortion in New Hampshire. Now it's time to put our words into action. New Hampshire for so long has had a long, proud, bipartisan tradition of supporting reproductive rights by voting against harmful legislation. But it's not enough to vote against abortion restrictions and bans. Our constituents would like us to vote proactively to support access to abortion. It's important. We as an elected body need to show Granite Staters our values, our priorities, and our firm and clear position. And we can do that by passing HCR 7. So I respectfully urge you all on the committee and our colleagues to vote ought to pass on HCR 7. A commitment and an action to not further restrict abortion rights in New Hampshire. And now I'll take any questions that you all have.
Thank you, Representative. Any questions from the committee? Yes, Representative Lamontagne.
Thank you for taking my question. Do you know of other states outside of New England that have passed such resolutions?
I don't. I mostly have looked at New England where the right to abortion up to 24 weeks is codified in state law. So there wouldn't necessarily be a need for a resolution like this.
Okay. Representative Polozov.
Thank you, Madam Chair, and thank you for taking my question. So this bill says that prior to 24 weeks gestation. So my question would be how you define comprehensive reproductive health care, because sometimes abortion is made based on threat to women's health, and sometimes it could be more of a choice. So would you define?
So from my perspective and the folks that I'm representing, it's really important that decisions about healthcare, reproductive healthcare and otherwise, are made between doctors and women. So doctors and the person who's pregnant. So I would leave those decisions up to healthcare providers.
Representative McLean.
Thank you, Madam Chair, and thank you for taking my question. So we have some varying statutes that are specific with respect to dates. So the Fetal Life Protection Act, it references 24 weeks And it has to reference a specific time because obviously you want to give people clarity, right? And the same thing we have with our fetal homicide law, which was used the first time last year, which basically sets it at 20 weeks. And you want to be very clear, so if in the case of the criminal action last year, the woman was 37 and the fetus was over 20 weeks. And so the person was charged with 2 murders as opposed to 1, but had the fetus just been 18 weeks, they would have just been charged with the 1 murder. So when it comes to the statutes, we have this specificity to be as clear as possible. But this is a resolution. And so I'm just wondering your thought process, rather than like say at a point of viability or something like that, you're coming in with a hard number, 24 weeks. And what was your thinking behind, that number specifically? Because it may evolve. So just if you could let me know what your thinking was towards the 24-week number.
Sure. So the law that's on the books, the Fetal Life Protection Act, is up until 24 weeks. So I use that as the resolution. Yeah.
Follow up? So just basically, that's our status quo, and I just want to kind of hold the line on that, basically.
Right now, in the law, that is what is in the Fetal Life Protection Act, and this resolution is attending to everything before what's in the law right now. Yes.
So you're just trying to preserve that status quo in the resolution, basically.
I'm trying to make a statement and have the House make a statement that we affirmatively support reproductive rights and health care up until 24 weeks.
Thank you.
Representative Mazur.
Thank you, Mr. Chair. Thank you for taking my question. So you just said right now you're in support of the 24 weeks. Would you be supportive of a resolution like that if for abortion up until birth?
I think that's an inflammatory statement. That's not an actual thing that happens in reproductive health care. It's not what we're talking about. We're talking about reproductive health care, and abortion at the time of birth is not a thing that happens in healthcare. So I'm not going to talk about that.
Quick follow-up.
Follow-up?
Quick clarification. I said up until birth. Not
Right. And I am saying that abortion up until birth does not happen. I think it might be helpful for you to ask that question of a provider of healthcare who may be testifying after me, but that's not something I'm going to talk about.
Other questions? I'm seeing no other questions. Thank you.
Thank you.
Also signed up to speak is Representative Mary Hacken Phillips, one of the co-sponsors.
Thank you, Mr. Chair, members of the Health and Human Services and Elderly Affairs Committee. For the record, I'm Representative Mary Hacken Phillips, serving Hanover and Lyme from the Grafton 12 seat, and I'm here today as a co-sponsor in support of HCR 7. So many, if not most, of the states practicing OBGYNs live in or practice adjacent to my district, more so than any other district in the state. So you may not be familiar, but Lebanon's Dartmouth-Hitchcock Medical Center is a mere 2 miles from my home. So I'm here to speak on behalf of New Hampshire's practicing OBGYNs who could not be here today because they're at work, on why abortion is a critical component of comprehensive healthcare in our state. So I'm going to share 2 academic studies with you and then an anecdote from one of those physicians for your consideration. So first, the Journal of American Medical Association, or JAMA, has a study published in February of 2024 that reports a statistically significant decline in medical residency applications were found in states with abortion bans. Fewer applications for residency programs can lead to a decline in the quality and quantity of young medical residents at the beginning of their career training in a program that will ultimately feed those residents into the hospital systems as attending physicians for all OBGYN practice areas. Yes, so that means fewer abortions in New Hampshire also means fewer OBGYN procedures for preventative care and reproductive care by fewer of the best physicians. Second, the Journal of American Medical Association study published in January of 2024 reports that OBGYNs practicing in abortion ban states perceived impacts that include distress in delaying essential patient care, fears of legal ramifications, mental health effects, and planned or actual attrition. So that's right, abortion bans cause New Hampshire's existing OBGYNs to suffer while they work to deliver patient care, to fear fines, imprisonment, and loss of licensure and retaliation for delivering care, to experience mental health challenges as a result, and then to become more likely to leave their states of practice for states without the abortion bans. So yes, fewer abortions mean fewer existing OBGYN care practicing physicians for all Granite Staters. So to sum up, these two studies' findings are directly reflected here in New Hampshire. Current law limiting one subset of procedures hurts Granite Staters' chances of receiving regular preventative maintenance and maintenance care for their reproductive health. And so we're damaging the sustainability of our existing and future OBGYN care here in the Granite State. Third, I'm here to relay an important constituent story for your consideration. An OBGYN physician who's a professor at the Geisel School of Medicine in the Dartmouth area, who is also licensed to practice here in New Hampshire and Vermont, reports that the legislative limits on this medical practice in New Hampshire are pushing him to stop offering his provider services in New Hampshire and move his clinical practice exclusively to Vermont. He feels that the laws regulating abortion care in New Hampshire are an unfair intrusion on his medical decision-making, which follow national standards of care, and are also an unfair judgment upon his medical expertise. He can easily move his practice to an environment more supportive of his practice without suffering repercussions. And there is nothing holding him back other than recognizing that New Hampshire would become more of a reproductive healthcare desert than it already is.
If you could start wrapping up, please.
Yep. So this resolution, if passed, would provide this doctor and the rest of the state's OBGYNs as a signal of support that New Hampshire trusts its OBGYN physicians and values their difficult work prior to the 24-week ban. So protecting this vital access to abortion care is just one important part of this clinical work, and passing this resolution will assure more doctors like him that New Hampshire is serious about giving providers all the tools they need to provide the best care for their patients and their patients' families. So it's an important moral victory I really think you should consider. So for these reasons, Mr. Chair and members of the committee, I urge you to support this resolution. And with that, I thank you for your attention and would be happy to answer any questions you might have.
Thank you. Representative Palazov.
Thank you, Mr. Chair, and thank you for taking my question. So you mentioned significant decline in some numbers as related to OBGYN and some enrollments. Could you put some number or in terms of percentage? Is it like 1% decline or like how much?
I'd be happy to forward you the study after this.
Other questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So, I mean, obviously, abortion is a very, divisive issue, and people come down on multiple sides of it. And so it can be a difficult discussion. But you talked about the fact that since our existing law went into effect, we've seen a loss of service, and you gave the specific example of a physician who moved his practice to Vermont, which is a tangible effect. So, in light of that, what is your objective? I mean, you could go back and you could revisit the statute, or you could look like some other states have done at a constitutional amendment. Instead, you're choosing the path of this resolution, which I don't really think has all that much teeth to it. So what are you seeing that the gain is going to be from this? I'm just trying to understand.
Thank you for the question, Representative. So as I was finishing up my remarks, I talked about the important signal it would send to doctors who practice in this field that New Hampshire's legislators actually care about people and they put people over politics, recognizing that this simple subset procedure of an overall practice is being limited for more or less arbitrary, purposes. It's, a policy decision. But if you were to support the resolution, you would let them know that the rest of their practice is supported and that their jobs and their hard work, their difficult decision-making prior to 24 weeks is valued, because we understand that this subset procedure for the overall practice is required prior to 24 weeks in many cases in order to keep the regular reproductive health care of our Granite State reproductive folks, in a healthy position. So I do not believe that they are separated. I think that these two things can live in the same space and coexist in a meaningful way. Just because we have something after 24 weeks doesn't mean that we can't affirm what they're doing prior to 24 weeks. So I think that signal is important for the physicians who are working here to address almost every single one of our families has a female who has been or will be or could become pregnant. So the support that you could show with this resolution would be very powerful for their morale, considering the previous attacks that they've had on their profession. But more than that, I think that the signal would also be sent to every patient family member, or simply persons who love a patient who could become pregnant, by showing them that we understand healthcare is complex, it's personal, and it's private prior to 24 weeks. And so that's the meaning of our resolution today.
Follow-up.
Thank you, Mr. Chair, and thank you for taking my question. So, and I understand, your comments about the moral position that it stakes out. In your conversation with the physicians that you're representing, have any of them commented to you, including perhaps this physician that's moving to Vermont, where they said, if this was to pass, even though this is something that structurally has no teeth, it would be enough for us to consider moving back?
Well, I can't put words into the person's mouth, no. But I have had several conversations with practicing physicians in the state who believe this this resolution or affirmative support of their work prior to 24 weeks is critical for what they do in the state. Not only because it would provide some legislative intent for, in terms of how the legislature feels prior to 24 weeks, but also because it would show, that professional support I was just speaking with you about, the morale.
Thank you.
Representative Markell, did you have your hand up? Then Representative
I did.
Palazzo.
Thank you for taking my question. So, ma'am, earlier we heard it discussed that there's no abortion, basically, if I heard it correctly, and perhaps you can clarify this for me, that there's no protections for abortion in New Hampshire. However, could you please comment on RSA 32944, which addresses the issue that basically says no abortion will be performed after 24 weeks unless there is a medical emergency? Isn't that enough for you to satisfy this particular call and satisfy the problems that you say some of the OBGYNs are having?
Thank you for the question. To respond, I would say the question addressed to the earlier prime sponsor was outside the scope of this resolution.
Okay.
So I would decline to comment based on that. It's not really the resolution we're discussing here today. I just don't think that's relevant to the discussion we're trying to hold. So I'm sorry, I can't comment.
Okay, thank you.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking another question from me. So in the bill title and in the bill you talk about critical component. So how do you define a critical component? Does it mean that it is equal in importance to other components, or are you saying that it's more important than some other components of healthcare?
Thank you for the question. No, if you'll go back to refer to my previous statements, I mentioned that abortion care is one subset of the tools in the practice area that OBGYNs are responsible for in their scope of practice. So I don't believe one is more important than the other. I think that's the idea of the resolution, is to show that each subset of the practice area is part of the comprehensive reproductive health care that all Granite Staters deserve.
Other questions? Representative McGrath.
Thank you, Mr. Chair. Thank you for taking my questions. I'm still confused by the doctor who's moving to Vermont. What are, if it's because of our abortion after 24 weeks, what is Vermont's law?
I am not fully studied on the expanded nature of the Vermont law, but my understanding is that they do have a constitutional amendment affirming the right to abortion in Vermont. So they have spoken in their law where our law is silent. So they have actually made affirmative protections in their law through a constitutional amendment. Our state has no affirmative protections in law prior to 24 weeks.
Representative Kesselring.
I suppose,
sorry.
just to end the comment, I suppose the doctor realizes that his practice, he's not under criminal threat for his full scope of practice in the state of Vermont, where he is under criminal threat and civil liability here in the state of New Hampshire. So his benefit to moving his practice in Vermont for his professional licensure purposes is a lower risk practice field in Vermont than it is here in New Hampshire.
Representative Kesselring.
Thank you, Mr. Chair. Thank you for taking my question. So I heard you mention about the doctors you're speaking for today. Is there in your study anything that shows the pregnancy rate decreasing in New Hampshire? Because I would be concerned that that would be one of the reasons that the doctors would leave.
Thank you for the question. I will make sure to forward both of the studies to the committee so that they can look. This is a national peer-reviewed study since the fall of Roe versus Wade and the Dobbs decision. So it just measured the I think 11 states that reversed the abortion rights since that happened. So I will be sure to pass along both studies to the committee so you can fully inform yourself of the Journal of American Medical Association's published studies from 2024. So that's like a short window of time to turn around the end of the Dobbs decision and these studies. But that information is limited, and I don't think it's siloed to which states other than the ones that have past bans.
Other questions? Seeing none, thank you. Also signed up to speak is Representative Janet Lucas from our committee.
Thank you, Mr. Chair, members of the committee. For the record, I am Janet Lucas, and I represent Grafton County District 7, which is Campton. I testify today as an obstetrician gynecologist with 37 years practice and instruction experience in a Catholic healthcare system. During my career, I served on numerous hospital committees, including the Ethics Committee, and as department chairperson. There are many life-threatening complications of pregnancy that, if allowed to continue, would result in death, severe disability, or the irreversible loss of the expectant mother's future fertility. These include placental and fetal abnormalities that cause maternal heart failure in the early second trimester, pre-existing maternal conditions such as certain congenital heart diseases, for example, Eisenmenger syndrome, pulmonary hypertension, kidney disorders, cancers, ectopic pregnancies, a history of postpartum psychosis, alcohol abuse, and IV drug use resulting in bacterial endocarditis. I encountered all of these and other high-risk pregnancies when the balance of maternal and fetal well-being challenged all caregivers involved to render the best care based on the most current information and technology available. When the patient was not from my practice, I was still often involved in the decision-making process as head of the department
and advisor to the hospital's CEO, who at the time happened to be a nun. There were times when the only option to save the mother's life was to medically end her pregnancy. As heartbreaking as that decision was for me personally, I never believed we had made the wrong choice. And it was an informed choice, made without the unnecessary pressure of policies originating from outside of the medical field. A study by the Tulane University School of Public Health found that states with more abortion restrictions had a 7% increase in total maternal mortality compared to states with few or no abortion restrictions. To quote the lead author of the study, "It is critically important that state-level policies related to women's access to comprehensive reproductive care services, including abortion, are evidence-based and guided by the primary goal of improving women's health and reducing maternal mortality." The numbers are not in dispute. In states with strict abortion bans, women are dying at accelerating rates. States with abortion bans or restrictions have adverse outcomes, including declining enrollment in their OBGYN residencies, departure of trained specialists to practice in other less restrictive states, just finishing up, maternity care deserts, and elevated death rates for women of reproductive age. It's well known that women make the healthcare decisions in their families. If they have a good experience in obstetric and gynecologic care, they are likely to refer their family members for other kinds of care to the same facility. Women also influence decisions on where their families will live based on quality of health care, education, and other factors. New Hampshire should be a welcoming state for all families who happen to have female members. I ask you to support HCR 7.
Thank you.
Be happy to take any questions.
Thank you. Any questions? Representative Lamontagne and then Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. Just so I understand correctly, you're working mainly for a Catholic health service. I imagine that they probably had policies that did not allow elective abortion, but in the case of a medical emergency, there was no prohibition to doing what you had to do as the provider?
That's correct.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question, and thank you for sharing your insights as well. Already in statute in New Hampshire is the statutory guarantee of unrestricted access to abortion through 24 weeks. This resolution basically preserves that. It says, yeah, we're going to at 24 weeks. But, you know, if you look at the ladder of protection being offered, the statutory protections far outweigh any protections that may be gained from a resolution. And so when I heard the earlier testimony about someone who had left to go to Vermont, the reason that they were leaving to go to Vermont was because in Vermont, it was higher up on the ladder still in that it was a constitutional protection. And so I guess what I'm still trying to understand is, having already achieved the statutory protection, which is higher than the resolution, I'm still trying to understand what it is that you're trying to achieve with this. I don't know that it's going to be able to, you know, bring back the physicians and the obstetricians, because the life-saving care, where you had to basically make the decision to save the life of the mother, that's all protected within the existing statute. So I guess what I'm trying to ask is, where does the resolution take you? Because it doesn't even give you that same level that the statute does. Thank you.
I think I'm looking at this more as a statement of reassurance to future physicians who are considering practicing here. I have, after 37 years of instruction, I have literally hundreds of graduates of the residency program where I was a clinical instructor. And I know that, because I'm in touch with quite a few of them, that many of them have made a decision to leave states who have enacted stricter abortion restrictions. And they are also leaving states where they are not aware of a firm commitment to protecting women's reproductive rights because they're concerned about the future. So I think that this resonates with me because I'm hearing about those decisions and I'm concerned about what could happen in New Hampshire.
Follow-up.
And so again, with the extensive conversations that you have with these folks, understanding that the law is already there, have you had discussions with them about this resolution? And, you know, is it a game changer in any way for them? Would it move the needle for them? Or, you know, I'm just trying to understand the substantive impact that this would have.
Well, for the former residents who are considering changing location, and if they look at the New England states, I know that they're not looking at New Hampshire for that reason.
Representative Weber.
Thank you, Mr. Chair. And before I ask my question, I am a co-sponsor of this bill, but it is my understanding that I am allowed to ask a question if I'm not testifying.
That is correct.
Okay, thank you. So to clarify, am I correct that the intent here, let me start at from the other end. Isn't it true that the criminal statute is a prohibition that starts at 24 weeks and goes forward, and whatever concerns I have about the way that's written for people beyond 24 weeks is irrelevant to this particular piece of legislation? But what this legislation does is speak affirmatively to the intent of the legislature about abortion prior to 24 weeks, which is a subject on which our current law is silent. And that's the difference.
Correct.
Thank you.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So I wonder about what effects this bill will have on New Hampshire. So as far as I heard from other sponsors of this bill testifying here today, that they look to attract and retain more specialists performing abortions to New Hampshire. So it's probably safe to say that there will be more abortions performed in New Hampshire as a fact if this resolution to pass. So can we say that this will have effect of New Hampshire having fewer kids?
I think I disagree with the premise of your question in that I don't believe this would attract or result in more abortions being performed. I think it would help to make sure that we had accessible and available reproductive health care to all women, and that abortion is such a small part of that. But when an OBGYN makes a decision on where to practice, that includes all of the other kinds of care that's provided.
Other questions? I'm seeing none. Okay, thank you.
Thank you.
Also signed up to speak is former Representative Kurt Welper.
Thank you, Mr. Chairman. Members of the committee, for the record, my name is Kurt Welper. I live in Stratford. I'm chairman of New Hampshire Right to Life, and I am here in radical opposition to this resolution. My written testimony, which I have already submitted online, talks about the legal history and the foundational importance of protecting life in our country, whether it's the Declaration of Independence, the Constitution of the state of New Hampshire, or the federal Constitution. All of those talk about the importance of enjoying and or defending life. Every one. Not taking life. So this says abortion is a cancer in our society and has corrupted virtually every area it touches. The law, medicine, and since we're talking about healthcare, reproductive healthcare, we'll talk about medicine. Prior to the abortion regime in our country, the Hippocratic Oath, for centuries, eons, prohibited anything that would even assist in the taking of the life of the preborn. It's only in the wake of the abortion regime in our country that the Hippocratic Oath was changed to remove that prohibition. And today's OBGYNs, many of them, have no sense that life itself is worth preserving. No. If you call killing healthcare, you can go to assisted death. Why not? We heard this over and over in the testimony on that bill this year and previously. Because medicine now includes killing. No, it doesn't. Healthcare is about healing and about extending life. So all of these things that you hear, and one of the things, Representative Polazov, I think, asked an important question. Would you define reproductive health care? Nobody will. Because nobody will. So we shouldn't absolutely should be totally opposed to any support for abortion. Even the Supreme Court of the United States, when it did Roe versus Wade, said if we knew that the object of that abortion was a human being, abortion would already be unconstitutional by the 14th Amendment. This is intolerable and useless on top of it. And I will answer any questions.
Thank you. Any questions? Representative McLean and then Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. So I'm going to kind of flip it a little bit and kind of ask you the same question that I was asking some of the previous folks who testified, on the other side of the bill. The way I see the hierarchy of this, I see we have the Fetal Life Protection Act. It, in my opinion, codifies that you have access for 24 weeks. And they've made their position as to how it would, benefit. But from your position, tangibly, within the pro-life community, what impact is this going to have? Because it has no teeth. So where do you see this having impact? How do you see this having impact?
The journey of 1,000 miles begins with the first step. The first step in the case of, again, abolishing all of our abortion laws, which has happened once before in our state's history, is to establish that, abortion's a good thing, and the House should be on record as supporting it. And that's what it's about. It is not about reproductive health care. It's about killing babies and getting the House on record, because if you approve that phrase, reproductive health care, without the definition, then it absolutely includes the killing of these preborn children. And we know that over 60 million healthy babies have been taken by abortion for no other reason than, and it, like I said, it has corrupted the medical industry to the point where now abortion is the first answer. If you get take a prenatal diagnosis Janet, test, and it says you have markers for fetal anomalies that could turn out to be serious. The first thing they answer, they recommend is abortion. And the testimony of women, legions of women, who were pressured to abort for these kinds of reasons, did and did not, is enormous. It's just the corruption of abortion. So,
Follow up.
No, thank you.
Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. In terms of, so you made a good point about medical profession and OBGYN profession changing its philosophy, but we have to deal with OBGYN the way they are today. And supporters of this bill who spoke before you, if I understood correctly, they say that without this resolution, we are going to scare some of OBGYN professionals and they will leave New Hampshire, move to Vermont or otherwise, and pregnant women will be left with no support at all in New Hampshire. So do you share any of those concerns?
well, yes and no. I mean, I believe women should have good health care. And pregnant women and their babies should have good health care. But that does not include killing the baby, because that's not protecting the woman's health in way over 90% of all cases. And it's not protecting the baby's health in any case. So I guess that's my answer to your question.
Other questions? Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. Is there any circumstances that you could envision where it would be of benefit for a patient to undergo an abortion?
So I got two answers to that. And again, it's yes and no. But the yes and no in this case depend on what you mean by abortion. All the abortion laws of which I am aware allow for the good medical treatment of the mother and for the treatment of that mother to be a cause of death of the baby. But the legal definition of abortion is the intentional killing of the innocent child. The intentional killing, right? If you terminate the pregnancy simply to get rid of the child, then that's an illegal abortion. That's punishable as a crime in our state, and many others, as it should be. But if the mother has an ailment, an illness, an emergency situation that's threatening her life, then trying to protect her life is an ethical choice that has to be made by the medical professionals. And as far as I know, even states with abortion bans still allow for that kind of treatment when necessary.
Other questions? Seeing none, thank you. Also signed up to speak is Lacey Fehrenbach.
All right. Hello, my name is Lacey. I am a New Hampshire born and raised. I come from Auburn, and I'm here to speak today about keeping abortion safe and legal in New Hampshire. And I think the person who just spoke before me actually did an excellent job of explaining to exactly why we need this. So as you can see, we have so many people who really don't understand a lot about women's rights, about women's health, about what abortion is and how it works and why people are getting it. And it's not really impacting them. It's a hypothetical that they don't like. Meanwhile, people like me and my friends who are married and trying to have children have all decided to stop because they are so afraid of what will happen if they do become pregnant in the next few months. And then everything that's currently happening in the current president's administration happens. New Hampshire residents are terrified right now to get pregnant and have children, the ones who actually want to, which means that families are going to be struggling to have these children, while people who are unable to handle children, let alone themselves, are going to be forced to carry these kids to term if we get rid of abortion. Now, I could sit here and say, yeah, we do have something already saying that it is protected, but we also have people like Chris Sununu who run on a platform of protecting abortion and health rights and then taking it away as soon as they're voted in. And so we need more protections to guarantee that you guys aren't going to do that and that you aren't going to be ripping away things that we already agreed on once, but then another committee disagreed to. That's what I have to say.
Any questions? Seeing none, thank you. Also signed up to speak is Dr. Young. I believe New Hampshire Medical Society, perhaps, or?
Good afternoon, and thank you for this opportunity. My name is Dr. Og Young. I'm a retired obstetrician gynecologist, and I'm before you today to speak in support of HCR 7. I practiced in Concord for almost 40 years. I'm a past president of the New Hampshire Medical Society, and I served on the general council representing all the obstetricians in the state of New Hampshire for 20 years. Also, I taught Dartmouth medical students. They would come to Concord for their third year clerkship in OBGYN, and they're still coming to Concord. When I was a third year OBGYN clerkship medical student at St. Paul Ramsey Hospital in St. Paul, Minnesota, we admitted a young woman with severe hypotension, fever and chills, and vaginal bleeding. Clearly, she was in septic shock and confessed to having had an illegal abortion the week before. We gave her IV fluids and the best antibiotics we had at the time, and then took her to the operating room to remove her perforated, infected uterus. Our patient was an honor student and captain of her high school basketball team. I asked her if she had informed her parents that she was pregnant, and she confided that her father was responsible for her pregnancy and that she'd rather die than tell her mom that she was pregnant. Unfortunately, she did die a few days later. I would tell my medical students this story as part of a history of medicine, a history of our OBGYN specialty. I explained that they would likely never see a young woman with a septic abortion because of Roe v. Wade in 1973, making certain that women were free to have access to legal, safe terminations of pregnancy. Unlike my older partners who trained in New York City during the 1950s, they would never have to watch women die of illegal, unsterile abortions, leaving often orphans at home. I emphasize that our country was not contributing to the estimated 22 million unsafe abortions annually in countries where there was limited access to safe abortion, resulting in tens of thousands of deaths and disabilities. Little did I know that politics would creep into the U.S. Supreme Court,
If you could start
and
wrapping
Roe
up,
v.
please.
Wade
Please start wrapping
would be reversed. Almost done. Abortion is not about politics. It's about safe health care for women. For women, the decision to terminate a pregnancy is difficult and deeply personal, a matter that should only be decided in private between a physician or a caregiver and the woman. Lawmakers who know nothing about practicing medicine or caring for women should be making this decision for her. Legislators who know nothing about a woman's situation in her life should never have a voice in her medical decisions, especially when it comes to pregnancy. Providing private, safe health care to women gives them control over their bodies and freedom to make this world a better place.
Thank you. Any questions? Seeing none. Thank you. Also signed up to speak is Danielle Janke. I'm not sure I'm pronouncing your last name correctly.
You're not, but it's okay. Most people
Sorry.
don't. It's Yankee. It's German.
Yankee, I'm sorry.
It's okay. No problem. Thank you very much for your time. My name is Danielle Yankee, and I am a new resident of New Hampshire. I am a first-year law school student. I will speak quickly, as I have a criminal law quiz at 2:45. I am originally from Michigan, where our governor and legislature codified abortion into our Constitution in response to the Dobbs decision. As a young, educated woman who hopes to have a family one day, it is a priority for me to live in a state that has access to abortion for whatever reason that may arise. Pew Research studies in 2024 on public opinion about abortion has 2/3 of Americans and 2/3 of women believing in access to abortion. I hope that the legislature and governor can take this initial step in this resolution to affirm the access to reproductive health care to ensure the health, safety, and prosperity of women in New Hampshire for years to come. Thank you very much for your time and consideration. I won't be taking any further questions at this time.
Okay, thank you. Also signed up to speak is Greg Kunkel, I believe it is. Again, I don't know if I'm pronouncing that name correctly. I apologize if I'm not. You've asked for 3 to 5 minutes, sir. If you could keep it closer to 3, I appreciate it.
Yeah, that won't be a problem. This is my first time testifying or having anything to do with the government besides voting, so I'm a little bit nervous, and
We have a question.
so I'll keep it
Can
as
you
short
spell
as
your last
possible so
name?
I don't screw up, and I forgot my stuff on the kitchen
Is
counter.
your last
anyway,
name
so-
Kunkel?
Yes, my name is Greg Kunkel.
Okay.
I am. I head up Abolish
Thank you.
Abortion in New Hampshire, and I'm here to oppose HCR 7. I am coming from an abolitionist standpoint, where what we want to do is we are committed to the total, equivocal, and immediate abolition of abortion in the state of New Hampshire. And so I've been listening a little bit to this, and it's just kind of I'm a little bit confused because, well, first of all, we're talking about abortion and healthcare like there's one person involved, but there are two. We're talking about a pregnant woman, and when we define pregnancy, I looked it up on the way in. Merriam-Webster defines pregnancy is of a woman having the condition of carrying an unborn offspring. So there's a second person involved in this, and we're just totally ignoring that person's standpoint. So I think that's important to consider and not lose sight of. And I think it's immoral to purposely lose sight of it. So we're talking about abortion, healthcare and abortion like it's the same thing, but it's not. It's two separate things. There's abortion and there's healthcare. They are not the same, and all this conflating, all this stuff really has no bearing here. Healthcare it's two words put together, health and care. It's talking about saving lives and making them well. Abortion kills a human being. Healthcare saves. There is no version of healthcare that kills a human being. And if you think that's untrue. If anybody thinks it's not a human being we're talking about inside the womb, then go ahead and take an abortion pill and give it to a pregnant mother who wants to have that child, and find out how quickly you are charged with homicide. Because if we're only talking about the mothers who don't want their children here, and the mothers that want their children, it's homicide if you go and mess with that. So what is abortion then? Abortion is defined as the ending of a pregnancy, the early ending of a pregnancy that does not result in a live birth. So by definition, a pregnant is a human being. Pregnancy involves a second human being in the womb, and by definition, an abortion kills. That's not healthcare. So I, from abolish abortion, totally oppose that. And furthermore, I think that to get right with this issue, it's not confusing. We've made it confusing by 15-week bills, 24-week bills, where it's wrong to kill babies here, but it's okay to kill babies there. Take our state's existing murder laws and apply them to when life begins at conception, which is fertilization. Thanks.
Thank you. Any questions? Seeing none. Okay. Thank you, sir. Also signed up to speak is Nancy Brennan.
Good afternoon. Thank you for taking my testimony. Nancy Brennan. I'm from Ware, and I would like to read testimony from a friend who couldn't be here. I told him I would read his testimony and pass it out. He is in support of HCR 7. Our state has arguably the strongest tradition of respect for personal individual privacy of any state. When I served in the general court many years ago, with only a small handful of exceptions, every member of this body upheld the principle as it applied to reproductive rights in general and to the right to choose abortion in particular. I urge all members of this committee to recognize that any failure to strongly support all rights to personal individual privacy will lead to an erosion of New Hampshire's privacy rights more broadly. Granite staters must proudly stand up for the rights of all, even those with whom we may strongly disagree. If we fail at that, ultimately, every citizen's freedom will be at risk. This is a statement from Rob Blakeney here in Concord, and I will give you those. I would just like to add that as a 76-year-old woman who lived through times before Roe, I knew of people who went through things. I don't know of anybody that died. My mother did, but there were people my age who could never have children after they had abortions that were unsafe. And I will say, I am in favor of this. I wish it was going to be enshrined in our Constitution. There will always be abortions. And if we pass bills to stop abortion, then women of privilege will still be able to get them. And the people who will suffer will be the people who can handle it the least. Thank you.
Thank you. Any questions? Thank you. Also signed up to speak is Beth Skayer.
Hi. Hi, my name's Beth Scare, and I'm a grandmother from Nashua. I'm here today to speak in opposition to HCR 7. I'll read a quote from Frederica Matthews Green, which I'll send to you later. The problem is that It's a Baby winds up in deadlock with It's a Woman's Right. The two statements do not refute each other, so no resolution is possible. What's more, they continue a pernicious fallacy that deadly conflict between women and children is a normal state of affairs. In no sane country are women and their own children assumed to be mortal enemies. Any culture that does so is slowly committing suicide. When we accept as normal the ripping of a child from her mother's womb, we violate something disturbingly close to the heart of the human story. In the land where women kill their unborn children, every lesser love grows frail. Please vote ITL on HCR 7.
Thank you. Any questions? Seeing none, thank you. Also signed up to speak is Claire and Taylani from Reproductive Equity Now. Taylani, is that correct?
Tayluni, thank
Tayluni,
you.
okay.
Good afternoon. Thank you, Chairman and members of the House Health, Human Services, and Elderly Affairs Committee. For the record, my name is Claire Tayluni, and I'm here on behalf of Reproductive Equity Now to speak in support of HCR 7. Reproductive Equity Now works across New England to make equitable access to the full spectrum of reproductive health care a reality for all people. As we've discussed this afternoon, as New Hampshire is the only state in New England without affirmative legal protections for abortion, either in its statute or in its constitution, granted staters are not impervious or immune to the threats to abortion care that we are seeing from states across the country and to the threats that we expect to see coming from the national level. These threats and the patchwork of laws governing access to abortion care nationwide result in chaos, in confusion, and harm for real people in real communities, including your constituents who need access to basic and essential health care that gives them the freedom to make their own decisions and to fully control their bodies, lives, and futures. This is why we are urging you today to act favorably on HCR 7, a resolution that will clearly and simply communicate to residents of New Hampshire that abortion is health care, that abortion is a critical component of comprehensive reproductive health care, and that it is the policy position of this body that an individual's right to terminate their own pregnancy prior to 24 weeks and control their own future will not be denied. Across the country, as I've noted, chaos and confusion abounds with regard to understanding the legality and accessibility of abortion care. Polling, for example, shows that over half of all American women are unsure about the legality of medication abortion in their state. HCR 7 offers an opportunity to combat this misinformation and confusion and to cut through the noise and help granite staters in particular cut through the noise with a simple message that abortion, as I've said, is a critical component of reproductive health care and that our state government will not infringe upon or deny this right to care. Granite staters overwhelmingly support reproductive freedom and believe that there should be a right to abortion in every state across the country. And so after Dobbs handed the fight for abortion access back to state governments, HCR 7 is New Hampshire's opportunity this session to take this positive action affirming reproductive freedom that granite staters are looking for. I'll finally close with noting that advancing HCR 7 aligns very closely with New Hampshire's very long-standing history and legacy of affirming personal freedoms, and we urge you to support the resolution. Thank you so much.
Thank you. Any questions? Seeing none, thank you.
Thanks.
Also signed up to speak is Liz Canada from Planned Parenthood New Hampshire Action Fund.
Good afternoon.
Good afternoon.
Thank you, honorable members of the House Health, Human Services, and Elderly Affairs Committee. My name is Liz Canada. I'm the Advocacy Director for Planned Parenthood of Northern New England and Planned Parenthood New Hampshire Action Fund, and we are in strong support of HCR 7. When the U.S. Supreme Court overturned Roe v. Wade in June of 2022, they took away the federal right to abortion. And since then, as of today, 19 states have banned abortion or severely restricted abortion. And that number has changed because of court cases and because some states have amended their constitutions. But the bottom line is that other states have taken action to further restrict abortion. New Hampshire, as we just heard as well, New Hampshire is the only state in New England that doesn't have any state law or state constitution protections explicitly listed. And I heard Representative Markle, you mentioned earlier the statute about after 24 weeks. And I just want to clarify that part of that same law is that there is no, I believe it's 329:49, there is no right to abortion. It says that a few lines later. And so we want to make sure that we are clear that in New Hampshire, we don't have protections. We don't have any statutory guarantees. In the fall, there was a survey that went out that showed 64% of Granite Staters want their state lawmakers to take positive, proactive action on abortion rights. And so HCR 7 before you, this resolution does just that. It shows that there is the position of the chamber that you will not further restrict abortion from what is already on the books. Voting against harmful legislation, I believe it was 2 weeks ago, the House voted to withdraw the 15-week abortion ban, which was great. We were in strong support of that action as well. But voting against harmful bills is one step in that process. The other is taking a positive action. And that's what this resolution does. It simply shows constituents that you will not further restrict abortion from what's already there. And that's why the 24 weeks is in the resolution, I believe. And it is a clear position that only you as lawmakers can take. There were a lot of elected officials who ran and talked in their campaigns about not wanting to further restrict abortion. And that's what this resolution says. It allows you to take that action and show that commitment explicitly through that vote. So we would urge you to vote ought to pass on HCR 7. Thank you.
Thank you. Any questions? Seeing none. Thank you.
Thank you so much.
Also signed up to speak is Stephen Scare.
Good afternoon, Chairman McDowell and distinguished members of the committee. I urge you to vote against this resolution. I believe in protecting human life since birth. Having said that, I understand that this does affect autonomy, and I respect those of you who see your job as to balance human life versus female autonomy. This resolution gives only one side. It takes the extreme position and teaches that human life has no inherent value for the first 24 weeks. And the calls for autonomy in this bill assume that it's only the woman who's making the decision about the abortion. It's very naive to think that abortions all happen without coercion. One salient example was with the scandal at the Sununu Center. One of the counselors impregnated one of the girls who was there and then took the child for an abortion to cover that up. And we don't know how many groomers or people prostituting young people are using this to cover up. It's not just a young woman's choice. I'm also wondering if there's any pro-life medical professionals that avoid areas where they might feel compelled to perform abortions. And that's something that I haven't heard anyone look at or study. When someone says something is science shows or is not in dispute, then it's a pretty good idea to check on that and dispute it right away to make sure it's right. To what degree there's a correlation between abortion restrictions and increased abortions. And just looking quickly here, they're counting incidents that really have nothing to do with abortion laws. And there's also a concern that these abortion pills, the medications that people are taking, they didn't go through any serious clinical trials. And how dangerous are they? No one's keeping track of how many are affected there. This is a statement that I really don't want New Hampshire to make. Let's at least acknowledge that many of us feel that life begins at conception, like science does tell us, and deserves to be acknowledged. Thank you.
Thank you. Any questions? Seeing none. Thank you. Also signed up to speak is Courtney Reed from ACLU, New Hampshire.
Hi, good afternoon, Chair McDonald and members of the committee. For the record, my name is Courtney Reed. I serve as policy advocate with the ACLU of New Hampshire, and I am speaking on behalf of the organization in support of HCR 7. To keep things brief, HCR 7 would send a strong message that in the live free or die state, there's no room for attacks against bodily autonomy and the right to make private healthcare decisions. HCR 7 also sends a message that the legislature understands the importance of the physician-patient relationship, and as expressly stated in the resolution, that an abortion is a critical component of reproductive health care. And to level set, abortion is a human right, and this right has been recognized by numerous medical associations. And as we've heard from previous hearings and other speakers, that in the wake of bans and restrictions that have happened after Dobbs across the country, now is time to take a stand to protect this right. Again, New Hampshire is the only state in New England that does not have an affirmative protection for abortion in its laws. And just some data after that fallout as to why it's so important for the legislature to take action now. In 2022, after Roe was overturned, at least 25 million women lost access to an abortion in their home state. HCR 7 offers an excellent opportunity for lawmakers to affirm their commitment to protecting reproductive freedom and oppose further restrictions and barriers to abortion amidst these attacks. Going further, we know that research finds that when access to an abortion is restricted, we see higher rates of maternal mortality, increased poverty, people are more likely to stay in abusive relationships, and there's a widening of socioeconomic inequalities. We've also seen in polling at the national level and in New Hampshire that a majority of voters support access to safe and legal abortion. So it's time for the legislature to recognize that by voting in support of this bill. I'm happy to take any questions, but I want to respect the time of the committee. Thank you so much.
Thank you, Representative Markell.
Thank you for taking my question. I notice in the bill that you're asking the House Clerk and Senate Clerk to each transmit a copy of this resolution to the President of the United States Senate Majority Leader, and the Speaker of the House of Representatives, the Governor of New Hampshire, the Attorney General of New Hampshire, and each of the members of the congressional delegation. Can you tell us, what do you think the anticipated responses would be? Let me rephrase that. What do you anticipate the responses from the federal aspects of this resolution to be? I'm sorry. No, go ahead.
Thank you so much for your question, Representative.
Sure.
I think I would defer to the sponsors of the bill to more appropriately answer that question. But to just ground in this, I just want to express that this is a policy statement, and I think that the policy statement that we want to affirm that abortion is a critical component of healthcare, that in the Granite State we don't want to see any more attacks or restrictions on this bill, is something that is meant to be transmitted broadly.
Thank you. Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. So this bill is written, refers to specific policy by President Trump. So I wonder Do you know if New Hampshire has any other law that specifically lists President Trump policy position in a positive light or otherwise?
Thank you for your question, Representative. I haven't seen anything in statute, but I am familiar with a few resolutions and other proposed bills that have cited the current and evolving landscape at the national level, which I think is part of the reason why this resolution feels so important right now, as there's just so much uncertainty about the stability of care in the Granite State.
Other questions? Representative DeLamus.
Thank you, Mr. Chair. Thank you for taking my question. Just because you are the representative of the ACLU, my question might be a little off-center. Does the ACLU believe that abortion should or could be used as birth control, and do you consider that health care?
Thank you for your question, Representative. Ultimately, I think that question is not rooted in the facts of what reproductive health care looks like, and I would defer to someone from the healthcare community to give you a better answer than someone representing the legal community.
Other questions? Seeing none, thank you. Also signed up to speak is Kathy Stratton from the New Hampshire Medical Society.
Good afternoon. Mr. Chairman, members of the committee, my name is Kathy Stratton. I'm the CEO of the New Hampshire Medical Society, and I'm speaking today on behalf of the Medical Society in support of this resolution, recognizing abortion as a critical, comprehensive reproductive health care. The New Hampshire Medical Society is a nonprofit, nonpartisan society of physicians and other healthcare clinicians. The organization's mission is to advocate for the well-being and betterment of public health in New Hampshire. The society envisions a state in which personal and public health are high priorities, and all people who live and work here have access to high-quality health care. As you've heard from the physicians who have presented, the clinicians, and the parents providing testimony today, elective abortion is a safe procedure and medical care and a life-saving medical process that takes into consideration the physical and mental health of a patient. The physicians on my board of directors, the council that governs the advocacy of the New Hampshire Medical Society, and the countless years of experienced physicians practicing medicine and taking care of New Hampshire citizens and families support this bill. The Medical Society strongly supports legislation that recognizes the clinical relationship between physicians and their patient within a well-informed clinical setting. The law codifies a patient's right to bodily autonomy and the right to receive safe and effective medical care. In conclusion, the Medical Society encourages the committee to support HCR 7 and ensure that individuals seeking health care in New Hampshire have access to a full spectrum of reproductive and life-saving care. Thank you for your time and consideration of our testimony.
Thank you. Representative McLean.
Thank you, Mr. Chairman. Thank you for taking my question. So our existing abortion law was passed in 2021, 1 year before the Dobbs decision came down. So if Roe was suddenly to be reinstated, nothing happens with respect to our law because our law is completely compliant with Roe. And so what I'm trying to understand, and I think is just with you, with the Medical Society, if this law was to pass, what would you do with it? How would you take action on it? How would it benefit you? Because we have a law that is fully compliant with Roe, I'm just trying to understand tangibly what you will do if this were to become to pass? Thank you.
It's my understanding this is a resolution, and that it's an important form of communication that says to patients what they have available to them for care, and that says to physicians that they have the support of the state to provide this medical care.
Follow up.
So if this was to pass, would it go into official communications that you send out to your membership, that you share with your patients? Or is it, and I'm trying to understand how it's going to be tangibly used. It's one thing to say, nevertheless, it's not, people deal with the law. They don't really deal with resolutions. So I'm just trying to, because it's a very divisive issue, and we're coming in and we're taking a stand when we went with the fetal life protection law. It was a compromise, understanding that there's this huge diversity of opinion with this issue. And so we're going in and we're muddying things up a little bit. And I just kind of want to understand tangibly, before I go in and kind of stir things up, how is it going to be used? How is it going to benefit? How are you going to put it out there? And I'm still kind of struggling to see what is the tangible effect going to be. Thank you.
I can't speak to other groups. I can speak to, the association. I think that this is, again, a support for the physician-patient relationship, for the autonomy of a woman, for her reproductive health. And, I can't speak to how the ripple effects that this will have moving forward. I can only speak to the importance of supporting that.
Thank you.
Thank you.
Any other questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Maria Wilkinson.
Thank you, Chairperson and committee members. My name is Maria Wilkinson. I was born and raised in Concord, New Hampshire. And as a Granite Stater, I know how granular we like to get about New Hampshire law and how focused we like to get into what it means to be living in New Hampshire. But I come with a master's in international human rights law, and I specialize in the International Covenant on Civil and Political Rights, and I support Article 6, the right to life. And at this moment, I would like to also say that I support HRC 7. And the reason I say that is because with a deep understanding of what international law says about the right to life, it's about the United Nations Human Rights Committee has never recognized that abortion is included into this right to life. It is under, it would be more well recognizing of the women attached to that pregnancy than anything. And I just really want to drive home that sometimes we get so singular in our focus, and sometimes the comments we get to opposition of something that's going to enrich our human rights in the state, we forget that there is beyond us, there is greater opinion. And I would like to also mention, why do we care about the International Covenant on Civil and Political Rights in New Hampshire? That's because the United States has ratified that, and therefore it's our duty under New Hampshire to also recognize what the covenant says. So I don't believe you'll have any questions for me, but if you want to ask me a question about international law, I will be willing to answer, specifically about the right to life.
Any questions? Okay, seeing none. Thank you. No one else has signed up to testify on HCR 7. Does anyone else wish to testify? If not, I am going to close the public hearing on HCR 7. Those are the only bills that we had to schedule for public hearing today. So I'm going to close this portion of our meeting. We do have, we will be going into executive session, and perhaps, I don't know, 10, 15-minute recess would be appropriate. I know at least one party needs to caucus. So we're going to be in recess for approximately 15 minutes.
I'm a new legislator. It's just what I've done.
Okay, I'd like to call the executive session into order. First bill to be considered today is House Bill 73. And interestingly enough, we are missing someone. So before we get carried away.
Stepped out.
The clerk.
Yes. Can't do much without the clerk.
While we're waiting,
Yes.
I had something from Mr. Williams about the Health and Human Services Oversight Committee.
That was the ALS thing?
Well, no, the thing is that I thought we were meeting on the fourth Friday, and it's
We are
meeting on the 21st
because
this
we're not in session next week.
That was it.
School vacation.
Okay,
Yeah.
I will have to change the lunch engagement then. Either that or you're going to have to clerk.
Oh, please change your lunch engagement.
I just need to get an update from all of us.
That
Logistical issue.
reminds me, okay.
That
Because I
can't-
carefully wrote in the minutes that it would be.
Because he raised that with the department or with John Williams at our last meeting, and they you know,
I'm
so,
remembering it now, thank you.
Okay, hold on. Now we lost Jim.
yeah.
Sorry.
You and Jim have a problem? Yeah, you don't want to be in the room at the same
He
time?
keeps getting conflicting messages from
No, we
OLS.
didn't have enough motion sheets. That was the,
Okay.
so Karen's bringing more.
And Jim keeps getting.
Just want to make sure there's no conflicts going on here. Thank you, Karen. Anybody got a pin? I want to see if I can really hear it drop. It's so quiet in here.
So we're waiting on 6:34.
We're waiting on, well, no, we're not starting with 6:34, but just waiting for everybody to be in the room before we proceed.
Jim's been waiting on an amendment that OLS possibly just let him.
That is the most focused look I've seen in anybody in a long time.
She's like, just move quick.
Yeah. No?
Expediting it. We could push that to the end.
Yeah, we will. Okay. All right, again, let's proceed. The executive session is open. First bill to be considered is HB 73, and Representative Drew, you had a motion, I believe?
Yes, I move to OTP HB 73.
Okay, and I'll second that. Do you wish to speak to your motion?
Briefly. HB 73 is some language changes to the statutes that, in my opinion, are frankly long overdue regarding reducing harm and treating activities that the state pursues and with regard to substance misuse the way that it should be treated. And that's pretty much it.
Okay, thank you. Any other discussion? Yes, Representative Weber.
As a result of the discussion at the hearing, I did actually have prepared an amendment that would simply amend the bill by replacing Section 8 with the following: "This act shall take effect 30 days after passage," because the effective date was pushed way out in the original bill. And so it was discussed at the time that the bill came up that perhaps having it take effect 30 days after passage would allow for the benefits to go into effect considerably sooner, because I think it was pushed out till maybe 2026 or something.
July 1st, 2026, yes.
Right. So I absolutely agree that this is a necessary measure, and I would hope that the amendment would be seen as a friendly amendment. And if it would be, I will pass it out and offer it.
Sure.
Or somebody else can offer it if
Is
you
there
would
any objection
prefer.
to this? Mr. Clerk? Good afternoon.
That's the only change, right?
That's the only change. It's very, let me just take one more for me. It's very short. It just says this effect shall take, amend the bill by replacing Section 8, which is the enacting clause, with the following: "This act shall take effect 30 days after passage."
Okay. And in terms of a friendly amendment, we don't have to have a formal vote, do we, or do we?
It's an amendment, we have to vote on it,
Okay.
yes.
All right.
But I would offer it, or I would defer to the
So
clerk
we
if
would
the
have to,
clerk
we would
would
have to
prefer
have the
to.
previous two motions removed, right?
Yes.
Yes,
the
I
okay.
think so.
Representative Drew, will you pull your motion on this?
Yes, I will
thing?
withdraw my motion.
I withdraw my second. Representative Weber, would you like to move this OTP?
I would like to move amendment HB 73. The number of the amendment I am moving is 2025-0219H, and it simply makes the effective date considerably, probably a year sooner than it would be if the bill remained in its original form. And with or without this, I will be supporting the bill, but I just thought it would give better effect to the intent of the bill.
Okay, and I'll second your motion.
Okay, thank you.
And any other discussion on this motion of OTP? Yes, Representative Palazov.
So I have some concern about this bill and this amendment making it even more faster, especially in terms of defining it as a reduction of societal and individual harm. So my concerns about studying how this wide definition can affect a scope and a cost of some services provided and otherwise. So I will probably vote with the rest of committee on the bill, but I think pushing it even faster is not prudent, so I will vote against.
Okay. Any other discussion? Yes, Representative Hartnett.
As someone who worked with Representative Bill Lieber on the initial creation of the Governor's Alcohol and Drug Commission, had we known in '99 of what harm reduction was, we certainly would have incorporated it into the initial legislation to create the commission. We would have saved countless lives, countless dollars in healthcare costs. Harm reduction is proven concept to help engage people in treatment, although that's not its primary target. Its target is really to reduce healthcare costs and illness. So I would certainly support this bill.
Okay, thank you. Any other discussion? Seeing none, I'll ask the clerk to call the roll. Motion is ought to pass on amendment 2025-0219H.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. DeLamis,
Yes.
Rep. Kofalt,
Yes.
Rep. Polozov.
No.
Clerk votes yes. Rep. Markell,
Yes.
Rep. McGrath,
Yes.
Rep. Kesselring,
Yes.
Rep. Weber,
Yes?
Rep. McKay,
Yes.
Rep. Woods,
Yes.
Rep. Palmer,
Yes.
Rep. Tejas,
Yes.
Rep. Lamontagne,
Yes.
Rep. Hartnett,
Yes.
Rep. Lucas,
Yes.
and Rep. McDonald.
Yes.
Vote is 17-1. Motion passes.
Thank you. Representative Weber, do you have another motion?
I would defer to the clerk on the
Oh, okay.
underlying motion if he chooses to accept my deference.
Okay. Do you want to move out to pass?
It's
as
basically
amended?
the same bill.
Sure.
Okay.
And I'll second it.
Okay.
I'll move OTPA on HB 73.
Okay, and Representative Weber seconds. Any discussion about TPA? Seeing none, when the clerk is ready. Motion is out of pass as amended on House Bill 73.
1 second.
Sure. When you're ready.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. Delamus,
Yes.
Rep. Kofalt,
Yes.
Rep. Polizov.
Yes.
Clerk votes yes. Rep. Markel,
Yes.
Rep. McGrath,
Yes.
Rep. Kesselring,
Yes.
Rep. Weber, Rep. McKay,
Yes.
Rep. Woods,
Yes.
Rep. Palmer,
Yes.
Rep. Tejas,
Yes.
Rep. Lamontagne,
Yes.
Rep. Hartnett,
Yes.
Rep. Lucas,
Yes.
Rep. McDonald.
Yes.
Vote is 18-0. Motion passes.
Okay, very good. That can't be consent, right? What can that be? Is that a, it's not a,
It's not an FN.
okay, so, any objection to consent? Okay, I'll go on the consent calendar. Yeah, Matt, Representative Drew, you'll write the report on that.
Yes.
Next up is HB 94FN. Representative Drew, you would, I believe you have a motion on that also.
I do. I move to OTP HB 94.
And Representative Delamus, do you have a second?
Yes. Second.
Do either of you wish to speak to your motion?
Yes. I think it's unconscionable that the state pays for a medical operation that is cosmetic and medically unnecessary in the vast majority of cases, and also the repair of botched operations when this operation is done incorrectly. So I do not believe that we should do that, and I urge you to vote OTP.
Okay, Representative Delamus, do you have anything to add to that, or?
No.
Any other discussion on the motion? Representative Lamontagne.
Yes, I am going to vote against this the ought to pass motion. After that testimony, I certainly came home thinking that routine circumcision of newborns is probably not a good idea. But I do have a problem that this bill is just banning the procedure for someone on public insurance and not for everybody. And in general, I'm opposed to that. I think it's probably a good idea that we have less, and maybe there are other ways of going about trying to reduce routine circumcision, such as maybe making parents wait a month so they've had time to think about it and maybe gather more information now that they've been home with their newborn baby. And before making that choice, I think a lot of it is that they have to make a decision like that while they're in the hospital. But it is the discrimination against just one group of people depending on their insurance. You know, and I have to say personally, my first husband was Jewish, and I agreed that our son would be circumcised in a Brit Milah that happened at the synagogue. But I came home from the testimony feeling a little distressed, and I called my son and I told him about the hearing we had. And he said, "I'm fine, Mom. I don't even think about it." I think the testimony was really skewed from one perspective. The vast majority of my peers were circumcised. I'm not saying that that's right or wrong, but I don't think it warrants our taking this action against just people who have one type of health insurance.
Thank you. Any other discussion? Seeing none? Okay. All right, the motion is ought to pass on HB 94FN. And the clerk is ready.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. Delamus,
Yes.
Rep. Kofalt,
Yes.
Rep. Polizov.
Yes.
Clerk votes yes. Rep. Markel,
Yes.
Rep. McGrath,
No.
Rep. Kesselring,
Yes.
Rep. Weber,
No.
Rep. McKay,
No.
Rep. Woods,
Yes.
Rep. Palmer,
No.
Rep. Tejas,
No.
Rep. Lamontagne,
No.
Rep. Hartnett, Rep. Lucas,
No.
Rep. McDonald.
Yes.
Vote is 10-8. Motion passes.
Okay, I assume there'll be a minority report on, well, it has to, oh, yeah.
So Matt is doing
He's doing the majority report.
Jessica, minority report.
Okay. Next up is House Bill 223. Representative Polazov, I believe you have a motion?
I move ought to pass on House Bill 223.
Representative Mazer?
I second.
Okay. Representative Polazov, do you wish to speak to your motion?
Yes. I move ought to pass an act relative to licensing requirements for healthcare facilities that operate within 15 miles of a critical access hospital. So this bill limits restrictions and will provide New Hampshire residents with more access to health care. We had very compelling testimony about importance of access to, for example, ambulatory surgical centers. And at the same time, the bill remains some protection for establishing a new hospital near critical access hospital, near existing critical access hospital. So I think it's a right balance, and I ask you to support it.
Thank you. Representative Weber.
I will just say that the old law, the current law, was a compromise back when it was passed, and then we've had various attempts to restrict it. And the concern that I had then and continue to have now is the effect that certain businesses may have on the funding structure of the critical access hospitals. Nothing currently prevents anybody from simply giving notice and having discussions with a critical access hospital and saying, the practice that we would like to establish is going to enhance your what's offered to the local population. But I think that we ought to continue to take that into consideration. So I will be voting no on the ought to pass.
Thank you. Representative McLean and then Representative Palmer.
Thank you, Mr. Chair. I think since our current law passed in 2016, I think we've seen access go down, not up. I think access continues to go down. Lakes Region Hospital went bankrupt, had to be absorbed by Concord Hospital. Franklin Hospital went bankrupt, had to be absorbed by Concord Hospital. So we heard testimony that it is very difficult to find a sustainable model for the rural areas of the state. And I don't know what the answer to that sustainability is. I mean, I'm not so arrogant to think that I do, but I do feel that the existing law and this 15-mile exclusion zone puts up a barrier to people who would innovate and maybe are able to go to find that solution. And so I think, this is just a small thing. And, during the questioning, Representative Weber asked a question where, and it really struck out to me. She says, listen, I live in a rural area, but it's not in one of these overlapping disc zones, and I haven't seen any development there. And I think that really says it all, in that you would think if this was going to come in and be a tsunami of people taking advantage of that, they would have already gone into Representative Weber's area, because everything is, there are so many interlocking discs that little small spot would be a magnet, you would think, for people to come in and develop. But it hasn't happened. So I think, the boogeyman that this is going to just throw open the healthcare market in the rural areas and it's going to completely destabilize everything, I don't think it's going to happen. I know that there is some risk for sure, but I think what we need to do on this committee is we need to have a realistic assessment of what the risk is and weigh that against what the benefit is. And I think realistically, if we do nothing, the model is not sustainable. So I will be supporting this bill, and thank you, Mr. Chair.
Representative Palmer.
So I have real concerns about this bill. If this bill were to allow primary care facilities to open within that range, I'd have no problem with it. The problem is that's not what's going to happen, because as we heard earlier during Dr. Nagel's discussion of his bill, it's very difficult to run a primary care practice in New Hampshire. That's really what we need. And I mean, we're also missing OB services. But a surgical center, there's a great example of what happens. So about 30 years ago, the surgeons and GI people at Valley Regional had a disagreement with the CEO, who was less than good at his job. And so they took all of their same-day outpatient surgery across the street and opened a surgery center, and they very nearly put Valley Regional out of business. And the difference between that and an independent surgery center open was that they still did follow their patients into the hospital. So if they had a complication in their surgical center, they took care of it. They didn't just say, go to the ER. But there's nothing stopping a surgery center that opens up on the other side of Claremont from closing their door at 5 and just having an answering machine that says, go to the hospital, in which case Valley Regional has again lost revenue. And the same-day surgery is the revenue that's a lot of the time keeping these hospitals afloat. And this year they've just had a 2.8% cut from Medicare on most services, so they're even less able to absorb it. So I get your idea, which is good. Let's try to get more services available to people. But I think this, as the bill currently is, what would happen is that it would be cherry picking. It would be people moving in and providing services that are well reimbursed, leaving the hospitals in trouble. So I think the only thing I would support here would be a further study to look at that and figure out how to make this work so that there's actually an increase in the services that we really need, rather than potentially putting critical access hospitals at risk for survival, because their margins. I mean, in New Hampshire and Vermont in the last years, most of the critical access hospitals in most years have been running at a negative balance. So if the OTP fails, I would support and be willing to participate in a study to try and figure out how to get past my concerns.
Other discussion. Representative Weber.
I just wanted to make it a little clearer as a follow-up to my question and the earlier comment by Representative McLean, that my point was really that in the spaces that are more than 15 miles away from from a hospital, not necessarily critical access hospital, but a hospital, nobody wants to build, because if there is an incident, if something goes wrong, if they need a hospital emergency room, surgical suite, other things on an emergent basis, they need to be a lot closer, and they need to probably be closer than 15 miles, depending on how hilly their country is where they are. So I don't think the fact that nobody has come to Walpole to establish one of these things is really determinative, because I think they need to be closer. And I think that anytime there's something that will result in positive synergy between the new group and the existing hospital is going to say, please come. It's only when they are going to be drained of important revenue that they are going to say, sorry, not happening. So for that reason, I'm still opposed. But I do applaud the concern with making sure that everybody has more access. I just don't think this is the way to do it.
Other discussion? Representative Woods.
Thank you. Just adding on to the Laconia example, they had difficulties, then they got bailed out. Can we imagine if there had been, say, a surgical center decided to go in there? I mean, Concord Hospital couldn't have bailed them out. So in that sense, not having the protections, we would be without even the hospital itself, which would really put a dire problem in that whole area. So just to bring that again, that issue of, dominoes do fall.
Any other discussion? Representative Tejas.
Hi, thank you. I appreciate that there's a concern about sustainability of rural access, but it is definitely not afforded by this bill. This bill would provide an opportunity for cherry picking and will most definitely undermine the fiscal viability of the critical access hospitals. They're called critical access hospitals because they're critical. And the current law allows the study, as Representative Palmer proposed we do studying. And no entity has been denied to date. So the current law suffices with affording what has been suggested here today.
Thank you. Anyone else? All right, seeing none, I'll ask the clerk to call the roll. Motion is ought to pass on House Bill 223.
Rep. Mazer?
Yes.
Rep. McLean?
Yes.
Rep. DeLamus?
Yes.
Rep. Kofalt?
Yes.
Rep. Polizov?
Yes.
Clerk votes yes. Rep. Markell?
Yes.
Rep. McGrath?
Yes.
Rep. Kesselring?
Yes.
Rep. Weber?
No.
Rep. McKay?
No.
Rep. Woods?
No.
Rep. Palmer?
No.
Rep. Tejas?
No.
Rep. LaMontagne?
No.
Rep. Hartnett?
No.
Rep. Lucas?
No.
Rep. McDonald?
Yes.
Vote is 10-8. Motion passes.
Representative Tejas is doing the minority report.
Right, and that will be an ITL.
Okay, sure.
Here he is.
Representative Polazov,
Regular calendar, yes.
regular calendar, yes, oh, yes. Okay. Next up is HB 524FN, Representative Mazer.
Yes, thank you, Mr. Chair. I move ought to pass on HB 524-FN.
Representative Brew,
Second.
you wish to speak to your motion, Representative Mazer?
Yes, thank you. The National Library of Medicine did an examination of the UP, the Universal Purchase Programs, as a driver of vaccine uptake among U.S. states back in 95 through 2014. And they found that UP programs were ineffective in increasing vaccination rates. And we find that DHHS should not be in the business of buying and selling vaccines for commercially insured children through this vaccine association. It is best to remove government from involvement in the purchase of medical products when private business does this quite well and cost effectively for vaccines for adults. This bill won't increase parents' cost to parents through deductibles or copays. Federal law requires that all vaccines for children be provided at no cost to the parent for the vaccines. This bill will not change that. Vaccines will still be required to be quote unquote free. This bill won't bring back measles. This bill will have no impact on vaccination choices or rates. There will still be tons of vaccines for everyone who wants them. This bill isn't anti-science. It has nothing to do with vaccine policy. It's simply a matter of who's in the business of buying and selling a private use medical product, the state or private industry.
Okay, any other discussion? Representative Lamontagne.
Yes, I can't support the ought to pass on this bill. First of all, none of the many pediatric clinics nor the insurers who are using this system came in to say, oh, it's a problem. We need to fix it. Because it's not a problem. It's working really well. And it's even if it's true that the insurance will be covered. You know, I thought back to when my own children were infants and I was a graduate student with very little income. And we went in to get our shots. I remember wondering if I had enough money to pay for all the shots that day. And I was assured, no, it's all taken care of. You take away the vaccine association, we go back to just, oh, the insurance companies will still pay for it. But then you have the parents going into the clinic wondering if that bill is going to be paid. The doctor's office then has to negotiate with the insurance company to make sure that gets paid for them. You're adding this level of complexity that will end up disrupting the distribution of vaccines simply by making it more complicated. We have a system that works very well, and I think we should keep it and not really decide on a whim that we should do away with a system that works very well.
Thank you. Representative Weber.
I agree with everything that Representative Lamontagne said, and the only thing I want to add is that, yes, the vaccines will still be available to parents at no cost, which is great. But the reason, the whole purpose of the Vaccine Association was to aggregate purchasing power to bring down the cost of procurement for everybody. And that means both people covered by the state and people covered by private insurance. And so and people not covered by anybody. So I think that to repeal a system that is working, that has been established voluntarily, that nobody in the system is complaining about, and which saves the state, the insurance companies, and ultimately the people paying the premiums for the insurance money, is really short-sighted.
Representative Woods.
Thank you. Secondarily, my opinion is that we'll see decreased vaccinations. A lot of the vaccinations are carried out by private practice. They will find it economically unacceptable and decide not to do vaccinations, at which point those who want vaccines will now have to find another provider. And that puts another layer on getting the individuals vaccinated, so vaccination rates go down, and all the accompanying problems with non-vaccinations. And I think it's a serious health problem.
Thank you. Representative DeLamus, did you have your hand out, or?
No, I did not.
Okay, sorry. Representative McGrath.
I think that the free market is really great at finding solutions. In the pharmacy, they rolled out the vaccines when COVID hit the market flawlessly, and the companies are definitely going to make sure that their products get into the correct hands. And secondly, the vaccine rates are already plummeted, I believe, because of the I'll say the lies that been coming out from government agencies. People used to be lined up for their vaccines, and nobody is coming in for their vaccines. Nobody wants them. So if we have the state buying tons of vaccines and running this program, I don't know what they're going to do with them all, because I could tell you from retail pharmacy, nobody's coming in for vaccines anymore.
Representative Kofalt.
Thank you, Mr. Chairman. So I think as far as access is concerned, I think, we see advertisements all the time from CVS and Walgreens and others of, come get your vaccine. It's free or very low cost. CVS in particular is, very closely affiliated with one of the pharmacy benefits management associations. I think they have the market power to buy in bulk, and that's an example of how the free market, I think, can address this issue without government intervention. So I will be supporting the bill.
Representative Lamontagne.
I'm sorry, but I can't help and look, not looking at this bill as an anti-vaccination bill. We have a system that works very well. And it seems like the motivation of this bill is to disrupt that system. And I happen to believe that vaccines work very well. My husband's father was paralyzed from the neck down from polio in 1955. It will be a horrible thing if children start losing access to the polio vaccine because we decided to disrupt a system that's working very well to distribute that. My husband, I'm sure he would have rather played baseball with his father in the backyard than spend his entire youth changing his father's bedpan. So think about what you're doing. This is not a problem that needs to be fixed.
Representative Polozov and then Representative Palmer.
Thank you, Mr. Chair. So we had two numbers, 30% discount and less than 1% administrative fee, but we have no way of confirming that it's actually effective because, like, to expand what Representative Kofalt said, like we often know if you are without insurance, sometimes you have huge cash discount, and insurance companies get discounts from service providers and drug companies. So definitely there could be discounts even better than 30%. We don't know. And the same with administrative costs. So we heard that the majority of actual administrative cost lies outside. It goes, for example, to DHHS and mostly covered by federal funds that might run out. So the remaining cost that was shown to us is the cost of having a simple spreadsheet, how much insurance providers paid and how much money went out. So paying hundreds of thousands for keeping a spreadsheet seems excessive. Thank you.
Representative Palmer.
So I guess I'm a little frustrated. On the one hand, vaccines have saved more lives than any other medical intervention ever, and they continue to do so in most of the world where they're being used. And in this country, we've vilified them for some legitimate reasons that, people, I guess, they're not perfect. So the first patient I saw when I moved to Claremont, the very first patient was a woman who'd had Guillain-Barré after getting a flu shot. On the other hand, we don't have 1918 versions of the flu. We did have COVID. That vaccine is effective. Countries that adopted it better than we do did ultimately better than we did with COVID. anything that we do that further denigrates the value of vaccines that is not legitimate. Should they be studied better? Should we have better vaccines? Sure, absolutely. But I think we've got to be very careful that we don't push this to the point where it's a self-fulfilling prophecy, that we make it a little harder to get fixed so that rates go down and we see nobody wants these. Well, I don't really agree with that. I work in Vermont where they have a similar program, and there it's crucial for the people who don't have insurance, because that's how they get them. Then they don't. Otherwise, it would be it would be up to the hospital or the doctor's office to provide them. The final thing, two things I'll say is where I go for my health care, there are some vaccines that aren't covered. The providers don't get coverage for the vaccines, so they don't offer them because they'd have to pay out of pocket to get the vaccine, and then all they could collect from me is the administration fee. And so I have to go to the pharmacy to get those vaccines, like the shingles vaccine. And so I did, because I had shingles when I was 19. I don't want to have it again. I have the time, the motivation, and the money to go do that. But a lot of people don't have that. So anything that makes it more difficult is going to be a problem, and ultimately end up a public health issue. And so my daughter had a baby last July, and basically is thinking of moving to New Hampshire. That child has had every vaccine to prevent illness, and what is my daughter going to think if she looks at going to school in New Hampshire and 70% of the kids are vaccinated, not the rest? I just think we got to be really careful about what we do with this.
Any final comments? Seeing none, I'll ask the clerk to call the roll. Motion is ought to pass on HB 524 FN.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. DeLemus, Rep. Kofalt,
Yes.
Rep. Polozov,
Yes.
Clerk votes yes. Rep. Markell,
Yes.
Rep. McGrath,
Yes.
Rep. Kesselring,
Yes.
Rep. Weber,
No.
Rep. McKay,
No.
Rep. Woods,
No.
Rep. Palmer,
No.
Rep. Tellez,
No.
Rep. LaMontagne,
No.
Rep. Hartnett, Rep. Lucas,
No.
Rep. McDonald.
Yes.
Vote is 10-8. Motion passes.
I assume there'll be a minority report. You're going to be a busy lady. Okay, next up is HB 634. Representative Kofalt, you have an amendment, I believe?
Yes, I move ought to pass on House Bill 634, and I would like to offer Amendment 0344H.
I already have a copy. Some may not, though. Amendment number is 0344H. Yes, Representative Palazzo.
I would like to second.
Representative Palazzo seconds the motion about to pass on the amendment. Do either of you wish to speak to your, well, after the, sure, sorry. I wasn't sure who had one and who didn't. Everyone let me know when you're ready. Representative Kofal, why don't you go ahead?
Thank you. So as I believe I said in our last exec session, I had reached out to a number of people I know who have family members with autism. They were uniformly of the opinion that the Autism Council has not been effective. It has not met in several years, and that the work that they are supposed to be doing is duplicative of work that is already being done by the Quality Council on developmental disabilities. So the amendment proposes simply to repeal the Council on Autism as it is duplicative.
Any discussion on the amendment? Yes, Representative Weber.
I'm going to be voting against the amendment because, as we heard, there are definitely concerns with the Autism Council as it is currently structured, but the bill was specifically entered to address those concerns and do the needed work over the next couple of years. The concern that I have is that if you depend on the Developmental Disability Council to represent folks with autism, many of the folks with autism do not qualify under the definition of disability. So they will be without representation. And I think that we owe them the courtesy of this opportunity to hear their voices in both forums.
Thank you. Other discussion? I would just say that I had received, as did Representative Kofal, a number of calls, unsolicited, some from my own town, about the council, very frustrated on how ineffective it has been, hasn't met since 2019, urging that it be repealed. So to the extent that there needs to be a forum to address autism, this isn't doing it, and I'm not confident that it will. So anyway, and again, this is based on people who have been actually dealing with it and actually have autistic children. So any other comments? If not, I'll ask the clerk to call the roll on the amendment. About to pass on Amendment 0344H.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. DeLamus,
Yes.
Rep. Kofalt,
Yes.
Rep. Polizov,
Yes.
Clerk votes yes. Rep. Markell,
Yes.
Rep. McGrath,
Yes.
Rep. Kesselring,
Yes.
Rep. Weber,
No.
Rep. McKay,
No.
Rep. Woods,
No.
Rep. Palmer,
He left. I believe he left.
Yes, he did.
Okay.
okay. Rep. Tejas,
No.
Rep. Lamontagne,
No.
Rep. Hartnett, Rep. Lucas,
No.
Rep. McDonald.
Yes.
Vote is 10-7. Motion passes.
Okay, Representative Kofalt, do you have another motion?
I move ought to pass with amendment on House Bill 634.
And I
Okay, and
second
Representative
Polizov.
Polozov seconds again. Any further discussion, Representative Kofalt, or any other discussion from members of the committee? Okay, I'll give the clerk a chance to
Catch up. Yes.
catch up and then call the roll when you're ready.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. DeLamus, Rep. Kofalt,
Yes.
Rep. Polizov,
Yes.
Rep. Clerk votes yes. Rep. Markell,
Yes.
Rep. McGrath,
Yes.
Rep. Kesselring,
Yes.
Rep. Weber,
No.
Rep. McKay,
No.
Rep. Woods,
No.
Rep. Tejas,
No.
Rep. Lamontagne,
No.
Rep. Hartnett, Rep. Lucas,
No.
Rep. McDonald.
Yes.
Vote is 10-7. Motion passes.
Chairman, I will write a minority report with a recommendation about to pass.
Okay, thank you. Okay, next up is HB 704 FNA. And Representative Representative Lamus, I believe you have an motion on that? Oh, okay. Representative Weber seconds. Representative DeLamus, would you like to speak to your motion? I mean, which one? Did I call the right one? I'm sorry. Representative DeLamus, I'm sorry.
Representative Weber might want to speak to it. I moved this because I have personal experience with this, and it's, I think, very important to support the people who take care of their loved ones who require 24/7. It's so heavy. It's so heavy that I nearly cried when we heard the testimony the other day on this bill. As much as I don't really like subsidizing things, I don't like growing government and spending money, I believe this is very worthy. This is a worthy cause that the people who are working so hard to keep their loved ones at home, save the state money by keeping their loved ones at home, and any little bit helps them. So I think that this is actually something that we, as a body in our government, should be supporting.
Okay. Representative Weber, would you like to speak also?
And I would just like to second everything that Representative DeLima said from a caregiver point of view, and the testimony that we heard was truly, truly moving. The other thing, and I had an email and I was unable to find it just now, but state expenditures for assistance for families keeping somebody at home run somewhere around $25,000 a year. If that individual has to go to a nursing home, it's more like $75,000 a year or more, because the specialized care that many patients need, particularly if they are dementia patients, is more expensive rather than less expensive. And as we all know, the patients who are the most difficult and the most medically needy come to our county nursing homes. And that is, of course, a charge on our local taxpayers. So for all of the compassionate reasons and for dollars and cents reasons, I'm very much in favor of this bill.
Other discussion, Representative Palazzo.
Thank you, Mr. Chair. I cannot support this bill with numbers as it written, but I must say that I agree that it's an awful situation and difficult situations when people have to care for loved ones 24/7, challenging for them. I also do not dispute that home care is more effective than nursing homes, but this bill, it's expanding government, it's incomplete system with cherry picking, it's encroachment into private sector and pushing out private charity. And one more reason is resources that we spend on addressing symptoms, we are not spending on addressing the cause of chronic disease epidemic here. And like I don't know if you want examples, but in previous sessions this committee did not support studying fluoridation of water, but later Biden's HHS confirmed that fluoride can be neurotoxic. So when we have some factors that we can address that can cause early dementia and other things, I think our focus should be also on those things. So I feel for the people, but I think that numbers in this bill just don't match the moment.
Thank you. Any other, Representative Kofal?
Thank you, Mr. Chairman. As a proponent of small government, limited government, I understand the concerns about spending, but as a proponent of small government, I would say this is exactly the kind of program that I believe we should be trying to support, which is loved ones, family caregivers, flexibility, providing that vitally needed support for people in their home at a time when they really, really, truly need it. So I will be supporting this one.
Thank you. Anyone else? Before I ask the clerk to call the roll, I was proud to be a co-sponsor on this bill. I went through issues with my mother with memory issues, dementia. She actually died 20 years ago next month, March 22nd. So some dates you just remember. So anyway, I understand all sides of this, but I was proud to be a co-sponsor with Representative Wallner on this. With that, I'll ask the clerk to call the roll.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. DeLamus, Rep. Kofalt,
Yes.
Rep. Polozov,
No.
Clerk votes yes. Rep. Markell,
Yes.
Rep. McGrath,
Yes.
Rep. Kesselring,
Yes.
Rep. Weber,
Yes.
Rep. McKay,
Yes.
Rep. Woods,
Yes.
Rep. Tejas,
Yes.
Rep. Lamontagne,
Yes.
Rep. Hartnett, Rep. Lucas,
Yes.
Rep. McDonald.
Yes.
Vote is 16-1. Motion passes.
Any objection to consent?
It's
Actually,
an FNA. It's an FNA.
Oh.
Yeah.
Oh, okay, so it can't go on consent. All right.
So no consent?
No, because it's spends money. It's a second committee bill.
Who's writing the
Representative DeLamus, you're doing the report?
Yes.
Okay, thank you. Okay, next up is 743 FN. And Representative McLean?
Who's doing the majority report?
Representative DeLamus. There is no minority report on that one. Okay, again, 743 FN, Representative McLean, did you have a motion?
Yeah, I'm gonna move ITL on HB 743.
And I'll second that. Would you like to speak to your motion?
Thank you, Mr. Chair. I'll be brief. The bill has two sections. The first section deals with the uninsured, and I don't really think it does any harm. It builds on the Federal No Surprises Act, and if that's all that the bill contained, I'd be okay with it. But there's a second component that deals with the insured persons and puts a lot of mandates on the insurance companies that the insurance department was not comfortable with. And you know, we're a small insurance market, and I don't want to do anything that would jeopardize coverage or actually move prices up. You know, I think that portion of the bill should have went over to Commerce, where they are used to dealing with these issues and have the subject knowledge. We heard testimony from the insurance department that HB 705 basically is a bill that is covering those components. So, you know, on balance, I would look for us to ITL this bill, and I'll be looking at HB 705 out of Commerce when it comes to the floor. Thank you, Mr. Chair.
Okay, thank you. Any other discussion? Representative Polozov.
Thank you, Mr. Chair. I agree that it could be the case that House Bill 705 deals with insurance part better than bill in front of us. but I think the part that addresses struggle of uninsured people is too important to throw out this bill at this point. So I would still be voting ought to pass, but I'm ready to testify at Finance Committee telling them that we don't need the insurance part of this bill. But I think it's still too valuable to throw it out. Thank you.
Other discussion? Seeing none, I'll ask the clerk to call the roll. A motion is ITL on HB 743 FN.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. Delamus, Rep. Kofalt, Rep. Polozov.
No.
Clerk votes yes. Rep. Markel,
Yes.
Rep. McGrath,
Yes.
Rep. Kesselring,
Yes.
Rep. Weber,
Yes.
Rep. McKay,
Yes.
Rep. Woods, Rep. Palmer still gone, Rep. Tejas,
Yes.
Rep. Lamontagne,
Yes.
Rep. Hartnett, Rep. Lucas,
Yes.
Rep. McDonald.
Yes.
So vote is 15-1, motion passes.
Is it an early bill? Okay. It's one of finance also, so that cannot go to consent. And Representative McLean, you'll do the report?
Sir.
Okay, we have one bill left that we're hoping to exec today, and that's 645 FN. There is an amendment that Representative Kofalt has gone to hopefully get from Committee Services. So if you don't mind just giving it a few minutes. I know we're tired, it's been a long day, but, and it appears, here he is, so it won't even be a few minutes.
That consent calendar?
Oh, no, it can't, because it spends money. It's got to go to finance.
So this is HB 634.
This is 645.
What?
Six,
This is 45.
yeah, we just did 634.
Oh, yeah.
Well, it was 10 to 7. And Representative Kofalt, I think everybody's got a copy.
Great. I move ought to pass on House Bill 645 FN and offer amendment 0505H.
And I'll second that. Do you wish to speak to your motion?
Yes, thank you, Mr. Chairman. So the chair of the Prescription Drug Affordability Board, former Representative Gary Merchant, asked me to put in this amendment because he believed that it clarified and improved the language in Section E of this bill. Otherwise, the bill and the overall intent of the bill has not changed. I think that so that's me speaking to the amendment. I guess I can speak to the bill at large if we pass the amendment.
Sure. Any other discussion on the amendment? Any questions? Seeing none, I'll ask the clerk to call the roll. Motion is ought to pass on amendment 2025-0505H.
Rep. Mazer,
Yes.
Rep. McLean?
Yes.
Rep. DeLamus?
Yes.
Rep. Kofalt?
Yes.
Rep. Polizov?
Yes.
Clerk votes yes. Rep. Markel?
Yes.
Rep. McGrath?
Yes.
Rep. Kesselring?
Yes.
Rep. Weber?
Yes.
Rep. McKay?
Yes.
Rep. Woods?
Yes.
Rep. Tejas?
Yes.
Rep. Lamontagne?
Yes.
Rep. Hartnett? Rep. Lucas?
Yes.
Rep. McDonald?
Yes.
Vote is 17-0. Motion passes.
Okay. Representative Kofalt, do you have another motion?
I do. I move ought to pass with amendment on House Bill 645 FN.
I'll second that. And other discussion from you? Or-
I'll just say that, I think that some concerns have been raised about the Prescription Drug Affordability Board, that it has not really been able to fulfill its mission. I think that this bill provides it with the tools that it needs to fulfill that mission, which is greater transparency in prescription drug pricing. And, with the ultimate goal of making prescription drugs more affordable. So I support this bill as a tool for making that happen.
Very good. Any other questions or discussion? Representative Woods.
More a comment. I think this is a step in the right direction, but I think underlying are such other items as PBMs and their relationship to this whole process, which are under discussion nationally and to some degree here. And I think hopefully this will allow us to get some of that and expose the PBMs and solve some of this cost problem. So I think this is, for that reason, is a good step in the right direction.
Good. Okay. Any other discussion? Representative Polazov.
Thank you, Mr. Chair. I share some concerns that there might be some added cost of compliance with this data sharing, and that we are creating one more commission that so far haven't done anything, but I see it as giving them a chance, and if in a few years we see that there's no progress, we can address it then. So I will join you in voting for this bill.
Okay. Any other discussion? Seeing none, okay, the motion is ought to pass as amended on HB 645 FN. And I'll ask the clerk to call the roll.
Rep. Mazer?
Yes.
Rep. McLean?
Yes.
Rep. DeLamus? Rep. Kofalt?
Yes.
Rep. Polizov?
Yes.
Clerk votes yes. Rep. Markel?
Yes.
Rep. McGrath?
Yes.
Rep. Kesselring?
Yes.
Rep. Weber?
Yes.
Rep. McKay?
Yes.
Rep. Woods?
Yes.
Rep. Tejas?
Yes.
Rep. Lamontagne?
Yes.
Rep. Hartnett? Rep. Lucas?
Yes.
Rep. McDonald?
Yes.
Vote is 17-0. Motion passes.
And again, this is an early bill, right? So that will go on the regular calendar. Okay, that is all I had for the executive session today. Before we adjourn, anyone have anything else before we leave? Again, the House is not meeting next week, but we are having hearings next week, which will be noticed in the calendar. We will not have an executive session, just hearings next week. So with that, unless anybody has anything, I'll declare us adjourned.